and author of the recent book, Fit Cities. She also teaches at the University of Alberta School of Urban and Regional Planning and Columbia University, Manhattan in New York. She served as the City of New York's inaugural Healthy Built Environment Director and Deputy to the Assistant Commissioner for Chronic Disease Prevention and Control during the Bloomberg administration. During this time, multi-sectoral partnership policy and environmental improvement efforts to increase supports for active living and healthy food access reverse childhood obesity trends and improve life expectancies within less than a decade. She is currently director of the Housing for Health initiative at the University of Alberta to recreate in Alberta and Canada the key processes that helped lead to the success in New York City. Welcome, Karen. So I will be helping Karen with her slide deck here. I'm just going to get my pointer out 1 second. Karen, are you here?
I'm right here. Can you hear me? Good.
I can't hear you very loudly.
Okay, can you hear me?
Okay, I think that everyone else can.
Okay, I see some folks nodding their heads, so hopefully it'll work out. I'll try and speak up. Is that better, Renika?
1 second. All right, I got you closer. Next slide.
Yeah, next slide. Thank you. So as part of the disclosures for this presentation, I do have grants within the last year that include private sector supports. I am a co-investigator on a grant that is in part supported by Novo Nordisk. I also have a grant supported by the Christensen Group of Companies, which is a development company in Alberta. And I've been given honoraria by firms like UN Studio to do talks, for example, in Europe. Other folks include my publisher is Penguin Random House, so that's a private sector company and it's disclosed here as well. Next slide, please. Also to say that, there is an honorarium being provided to speakers in this update this morning, and that I am a part of the group receiving an honorarium. Thank you very much. But the content of my presentation is not influenced by the supports. Thank you. Next slide, please. And of course, as with the slide you've seen earlier, as with the rest of the conference, the content was developed independently by myself, and it is for the purposes of education. It's balanced, it's based on the available evidence currently and available data from sources like World Health Organization and other academic literature. Next slide, please. So the learning objectives for this morning include, I wanted to discuss how a community environmental approach can help us prevent and manage epidemics such as obesity and their associated risks, including how we can improve physical activity levels and help with healthier diets through our community environments. Employ practical everyday interventions to improve physical activity levels and healthy eating supports for patients with obesity, and support and become involved in community environment improvement initiatives for supporting physical activity and healthier food access. And there are initiatives right now that are occurring within our own province that I will share with you in the course of the presentation. So, I've heard a lot from clinicians, for example, about the challenges that they face once patients leave their office and return home to an environment where they're having challenges with, for example, maintaining a healthier diet, maintaining the physical activity that we're counseling them about. So this presentation is going to touch on what are the types of things we can think about, and what are the opportunities to work with, for example, folks like myself in public health and preventive medicine, where initiatives can be created to help with creating better environmental supports in the community once your patients leave your office. Next slide, please. All right, we're going to start with some interactive polling. Did you guys have all just practice? And then we'll go into the meat of the presentation. So we're going to start with some questions about some data on obesity in Canada. So the first question is, over the last 40 years, what has happened to the prevalence of overweight and obesity in Canada? Has it A, decreased by 10%, B, increased by 10%, C, increased by 20%, or D, increased by 30%? Okay, we're going to go to polling, and Renika is going to help me open the polls.
Okay, so you guys, I'm going to teach you how to do this. I'm going to launch the poll, and you will see all of Dr. Lee's questions. So just look at the first question for now, and go ahead, submit your answers for the first question. Pardon me? It's not allowing to submit. You have to answer all the questions to submit. The submit button is not. Oh, you just have to click it. Okay, I think we have 2 people submitted, so oh, now it's going. Oh, hold on.
They have
just
to do
answer
all
the
questions.
First question.
We could do all 5 questions. It's okay. I think it's saying, people are saying you have to do 5 questions in order to submit. But
you
it's
have
okay.
to answer all the questions to submit.
It's okay. We could do it that way and then click through the other slides quickly.
And then we'll go back to it.
Oh, this is a technical glitch. That's all. All right. So Karen, how do you want to do it? Do you want to go through the first question?
Yeah, I think we should go through all 5 questions and then let people submit, and then we'll go through each one in the presentation itself. So let's just scroll through. You can see on the screen, the first question is, over the last 40 years, what has happened to the prevalence of overweight and obesity in Canada? So pick your answer out of the 4 that are there now. And then we'll have Renika scroll down the screen so you can answer all 5
Scroll
questions.
ahead to the second question, submit your answers. I can see lots of people putting in their answers.
Great. So the second question is about how Alberta compares to Canada in terms of obesity rates. Is it lower, the same, or higher? Submit your answers.
And then what are the physical consequences of obesity?
Yeah, so I think, Renika, you'll have to scroll down because I can't see your screen for number 3.
Yeah.
So
individuals can scroll down and look
can.
at the questions. They're in sequence. Yeah. And then we'll go and answer them after.
Yeah. So you have a whole host of answers you could pick from for number 3.
And then we'll go through all the answers.
Mm-hmm.
I just still see some people submitting answers, so take your time.
And then number 4 is, what are the psychological consequences of obesity? And number 5, what are our annual costs due to obesity?
Yeah, you guys can actually go back and forth and look at all the questions. All right, it looks like most people are done. So you guys, I'm going to go ahead and end the polling question. This just became an issue last night. And the reason was that Zoom doesn't allow for an excessive number of questions. They capped us late last night. And so we had to figure this out. So I'm going to end the polling question. So we will then, with each presentation, go through all the questions, I believe. All right, so let's review them. Over the last 40 years, prevalence of overweight and obesity in Canada, most of you guys thought the correct answer was increased by 30%. and then we'll go through and look at the answers after here. The prevalence of obesity in Alberta compared to Canada as a whole, most of you guys thought it was higher. What are the physical health consequences of obesity? And you guys can scroll down and share the results, look at the results with me. Vast majority of you guys thought all of the above. And then what are the psychological consequences of obesity here? Again, the vast majority of you guys thought all of the above. Oh, sorry. Can you guys see it now? I have some people on video, so it's nice. So now you can look at the answers. Right? You can see it, Sabrina? Yeah, okay. So just scroll down and take a peek. Okay, I'm gonna stop sharing.
Okay.
All right. So the correct answer here is 30%, increased by 30%. Go ahead, Karen.
Yeah, that's right. So this slide just is reviewing the rates of obesity in Canada from 1978 to 2017 in both adults and children. You can see that the rates of overweight and obesity in 1978 was at 49%, and by 2017 we're at 64%, or about 2/3 of adults are now overweight or obese. And in children in 1978, 23% of children were overweight or obese, children aged 2 to 17. And by 2017, we are now at nearly 1 in 3 children at 30%. Next slide, please. All right, and then obesity prevalence in Alberta compared to Canada as a whole. This is a very knowledgeable crowd. Basically, it's higher. That is correct. Most people chose that. Next slide, please. So this is the next slide shows you a map of Alberta compared to the other provinces in Canada in terms of obesity rates. And you can see the Canadian average in 2017 is 20% of adults are classified as obese. In Alberta, we're higher at 29%. And you can see actually most provinces, except for Ontario and for British Columbia, are actually, and Quebec, are actually at higher rates, and they are particularly high in the maritime provinces. Next slide, please. Again, very knowledgeable crowd in terms of physical health consequences of obesity. I believe most people chose all of the above, and yes, the answer is all of the above, and in fact more. So, I think we typically know that obesity is associated with increased risks of cardiovascular disease and diabetes, but there are a whole host of other diseases, including multiple cancers, and then of course, issues like obstructive sleep apnea, fatty liver disease, and infertility. Next slide, please. And this slide just basically is, a human diagram of the entire list of systems in our bodies that are impacted by obesity. Next slide, please. What are the psychological consequences of obesity? I believe, again, most people got this answer right. So it could impact depression, anxiety, body image disorders, self-esteem, stigma, eating disorders, feeling misunderstood or excluded socially, impact quality of life. And so correct, the answer is all of the above and more. Next slide, please. This is just a chart of how obesity, how BMI levels impact both men and women in terms of depression and anxiety. You can see that for both depression and anxiety, as BMI levels increase, except for if you're underweight, and there are issues associated with that as well. But for those who are normal weight and above, you can see that with each BMI level that increases, that anxiety and depression also increase, and that occurs in both men and women. Next slide, please. And costs, huge costs. that are contributing to our provincial healthcare budgets and potential sustainability of our healthcare system in Canada. And in addition to the healthcare system, you know, these budgets actually, our healthcare budgets are a very important source of our overall budgets in every province. What is the annual cost of obesity in Canada? Again, I think most people got this right, Ren? Which is that it's 7.1 billion annually, and it continues to increase. Next slide, please.
Yeah, I think they actually figured out that the answers to all the questions, Karen, were the last answer.
Pardon? Yeah, no, it's okay. All right, so I'm going to formally go into the presentation now. So I wanted to highlight, you know, the health priority crises across time and historically. Now, I know we're living in an age of COVID currently, and we're all in the heart of that pandemic. But if you look at the situation outside of the pandemic in this current century, chronic diseases, including issues like obesity, are now our leading cause of mortality, morbidity, healthcare costs, disability. In fact, even during COVID, if we think about risk factors for severe morbidity and mortality, one of the key risk factors is obesity, and other key risk factors include consequences of obesity, like some of our chronic diseases. So even in the current situation of the pandemic, these underlying conditions continue to play a really important role. So previously, if you look at the 19th and 20th centuries, you know, issues like cholera, infectious diseases, reproductive health, including maternal and infant mortality, safety issues. For example, before the days of building codes and, you know, road standards, you know, lots of injuries from that were caused by the environments that didn't have sufficiently safe standards, right? And we actually addressed many of these diseases through how we thought about the community environment. We introduced sanitation systems and water systems that helped us to get rid of diseases from the developed world, like cholera. You know, we introduced even like issues like good ventilation in our buildings, you know, ensuring that windows must be put in every building, for example, that helped to, for example, allow sufficient ventilation that helped to prevent transmission of things like respiratory diseases. Safety issues are impacted by how we design everything from houses to our streets to our commercial buildings. So there are standards whereby, you know, you have to design to code so that the building doesn't suddenly just fall down. Today, we've got a different set of diseases. So we've successfully actually managed a lot of these diseases of the 19th and early 20th centuries. And we've transitioned epidemiologically to a new set of diseases and conditions. So chronic diseases, which we're going to talk about today, aging populations, of course, which are at higher risk of getting these chronic diseases, mental health issues as well, climate change and environmental pollution are also major issues. Now, of course, we still have emerging infectious diseases. We're seeing that through, you know, new diseases like COVID, which will always periodically arise. We also have issues like antibiotic resistance that are part of this emerging group of diseases. And we still do have preventable injuries we have to address, of course. Next slide, please. So this is just a slide, you know, okay, so Renica, I think this is still my old set of slides in the sense that there are some errors in the previous set. It's okay. The new set that is posted on the website should reflect my new some errors that were corrected. For example, the reference below should be saying WHO 2018, not the 2010. And that was corrected in the latest set. So the one that'll be posted on the website for you will reflect the latest set. that I had sent Renica yesterday. I noticed a couple of errors. Anyways, chronic diseases are not only the #1 cause of death now in the developed world, but even in the developing world and globally. So it's the #1 cause of death, 41 million deaths per year. Over 70% of deaths are now accountable from chronic diseases. And some of the leading causes are heart disease and strokes, cancers, diabetes, and chronic lung disease. Leading risk factors accounting for a large percentage of these deaths include tobacco, inactivity, unhealthy diets, harmful use of alcohol, hypertension, overweight and obesity, high cholesterol. Now, all the ones that are in red, you could see, are actually associated with each other, right? We know that inactivity and unhealthy diets are really key pieces of the equation of hypertension, high cholesterol, overweight, and obesity. And they're also highlighted because, you know, we've done a lot, for example, in the Canadian context around tobacco. But these other issues, we still have a long ways to go, particularly in how supportive our community environments are in helping people with maintaining physical activity and with being able to keep a healthy diet. Next slide, please. Okay, so again, this slide was updated, Renica, in the updated slide of a set of slides that will be posted. The obesity is a global epidemic now. Essentially, you know, it has more than doubled since 1980. If you look at the stats going a little bit back into the 1970s, it has now nearly tripled. And these stats show you the 2014 stats, but if you look at 2016, they're quite similar, but even a little bit higher. So for example, more than 1.9 billion people are considered overweight. That's about 39% of the population. And of these, over 600 million were obese in 2014. By 2016, which is in the new set of slides, over 650 million are now obese. And you know, also about 40 million children from around the world are overweight or obese. And if you look at both children and adolescents, we are actually into the hundreds of millions as well who are overweight and obese. Next slide, please. So Renica will post the, just make sure you post the updated slides that is corrected for a couple of these errors. High levels of physical inactivity in Canada. This is a slide from Participation. This is a slide from Participation that basically shows that you look at children, so adults need 150 minutes per week of moderate to vigorous intensity physical activity to be and to maintain their health. Children, 60 minutes daily. So that's 420 minutes a week. In terms of actual activity levels needed to maintain weight, studies show that they tend to be higher than the recommendations needed to maintain health. So, but even at the level of just maintaining health, only 15% of our adults appear to be getting the recommended minimum amount of physical activity needed for health benefits, and only 5% of our children. You may see higher figures when you see, for example, survey results. I want you guys to keep in mind that when you see survey results that show that nearly half of adults may be meeting recommendations, those are based on self-report. We know that there are biases based on studies that have been done when people self-report their heights and weights. So men have been shown to tend to over-report their heights, and women have been shown to under-report their weights. And so the ratios of weights to heights, when you actually measure people, often tend to be even higher. So BMIs tend to be higher than when people self-report. So when you actually look at measured physical activity in studies that have been done, they actually tend to show very, very low rates of physical activity in this order of 15% of adults in Canada, and in children only 5%. Next slide, please. So I wanted to talk about the potential collaborations that can be done between public health and preventive medicine and clinicians and folks who are actually working with patients day to day in their offices, working on obesity issues. So these are a whole host of documents that I've been involved with in trying to improve community environments through collaborations. I think Renika mentioned at the beginning that I'm author of this book called Fit Cities. Fit Cities actually captures a whole bunch of stories about this work, particularly from my time in New York City. So if folks are interested after this, there's stuff you can read, and you can find a whole bunch of these on my website as well. Next slide, please. Okay, so some of the lessons, I think, in terms of the need for collaborations include, I've mentioned at the beginning that, if we look at how we have successfully conquered many diseases that previously used to be epidemic, whether it's safety issues or infectious diseases, we know that there are lessons to be learned from those successes of the past. It's important to actually have an evidence base for key risk and protective factors and evidence base for potential solutions that can occur. That is absolutely key when we're seeing patients. Well, there's a similar set of evidence base that is emerging and getting stronger as well when you look at community level interventions. And I'm going to share some of that with you today. We can also learn from what other jurisdictions have done in terms of some of these collaborations, and then adapt it to our local context. So we don't always have to just start from scratch. And in fact, in this space, there have been jurisdictions, for example, like New York City, that have actually successfully demonstrated that this can be done, and it can lead to really important results. Next slide, please. So what some of the key lessons from previous public health successes include: if we can identify a set of preventable risk and protective factors and ways to intervene on them, then we can do something about them. We often use a standard set of activities that can occur in different settings, and we apply those standard set of activities to monitor, to prevent, and to manage disease in each of those settings. Next slide, please. So, applying some of the lessons, one of the key things is to identify key preventable and risk factors and how and the sort of pathways by which they may be propagated on which to intervene. So in the case of obesity, physical inactivity, sedentariness, unhealthy diets, and then issues like social determinants that can impact on these risk factors, like working conditions, for example, social isolation and lack of social support that can exacerbate these conditions. These are factors that are actually impacted by our community neighborhoods, our streets, our buildings, by the physical and social environments of different settings, such as work sites and schools, and how supportive they may be of physical activity and of healthy eating, are examples of places where we can intervene. Next slide, please. So I want to show you some evidence-based solutions in the community space. So in the US, there's actually a task force called the Task Force on Community Preventive Services. It's the equivalent of the US Task Force on Clinical Preventive Services, right? And it is actually organized, this task force, by the US Department of Health and Human Services, of which the US Centers for Disease Prevention and Control is a part. So one of the things that the task force does every year is it actually identifies a list of priority topics that it's going to undertake a systematic review of the literature on. And over the years, if you go to www.thecommunityguide.org, you can actually, and you go to topics, you could see the entire series of topics that the US Task Force on Community Preventive Services has undertaken systematic reviews on over the years. They include obesity, they include physical activity, they include nutrition and healthier diets. So for folks who are interested, please check that out. Anyways, community design include elements like, it's been shown that if you have neighborhoods that have a sufficient density of people, and that density is actually achieved through having different types of homes in that community, right? So if you only have large single family homes, usually within a given space, you can have a limited number of people. If you have a limited number of people, you actually aren't able to support the amenities and the services near them to survive. So if you have a mix of homes that include not just large single family homes, but within the neighborhood, areas that also have, for example, condo buildings, apartment buildings, you can have more people in them. When you have more people, then you can locate those residential areas close to stores, to jobs, to schools, to recreation facilities, and other amenities. When you have those places close to you, studies show that particularly if you are connected to those places by safe streets and sidewalks, by things like bicycle lanes, then more people will actually do more walking in their daily lives to get to these environments. Safety of the environments for crime and for traffic. So if you can cross the street safely, if there's good street lighting, if it's actually pleasant to walk around in that community, then again, more people will be out walking around. You can shape that through partnerships with planning, for example, planners, transportation officials, etc. Even by working with developers and builders, because those practices and how they intersect with the street actually impact the pleasantness and safety of walking around in your community. Studies show that when you actually design communities to have walkability, as an example, safety, being out on the streets, etc., that there are associated outcomes of over 160% improvements in physical activity in those neighborhoods, increased sense of community by people and decreasing isolation. If people are out walking around, there's a higher chance that you'll run into your neighbor, right? As an example. And those types of communities are often also associated with reductions in crime and stress. So more people walking around, often more people have eyes on the street, right? There's nothing that feels often as unsafe as when we're alone on a dark street with nobody else around. But when there's lots of other people milling around, often the sense of safety can be increased. When I was in New York, we actually worked across different partners. So, the city planning department, the transportation department, housing, public works, to actually create a set of guidelines called the Active Design Guidelines. And you can access a lot of these resources at my website, drkarenlee.com. There's lots of them that you can take a look at. Peer-reviewed publications are also there. But anyways, we were able to work across different sectors to take the evidence and to put them into a set of guidelines for the city's planners, transport departments, housing department, et cetera, to actually use regularly in how they renovate the city, construct new areas in the city, and new buildings and stuff like that, and when they're updating streets, et cetera. So these are things that all can be done in other jurisdictions as well. And there's this picture that you see on the right, Guide for City Leaders. I was also involved in this document to actually help additional city leaders to integrate use of issues like guidelines. I was going to mention that if folks are interested, please take a look at some of these resources. Next slide, please. Street designs complement community designs. So I've mentioned, for example, things like improving street lighting, safety of street crossings, even enhancing landscaping can impact what happens. So again, complemented to community design, these are also associated with further improvements in physical activity, decreasing people's isolation, decreasing people's stress and crime in communities. Next slide, please. Complementing this, of course, is we spend a lot of our time daily in buildings. And so what we put into buildings can also impact whether people can incorporate daily activity into their lives, as an example. So simple signage, like this burn calories, not electricity sign. So I think we often think about, giving people information, but the literature is actually showing us that information that we place at people's point of decisions are probably the most effective information in stimulating and helping people with behavior changes. So it doesn't mean that if someone reads something on the internet or you give them literature like a brochure to read, that even though that may impact their knowledge and awareness, often it is insufficient to actually impact their behavior change. But when you actually place information that remind people in their daily lives of behavior changes that are good for them, like for example, take the stairs when they're standing waiting for the elevator, or when they pass by a stairwell and outside the door there's the signage. Those point of decision information actually have been shown to be effective. In the case of point of decision stair signage, it's been shown to increase physical activity by 50%. I was involved in a study in New York where we did this in an affordable housing building, and at 9 months later, we were finding that it was still impacting increases in stair use above baseline levels. And that wasn't just using the stairs going down, that was actually using the stairs also going up. In very high-rise buildings, you can actually reprogram elevators so that they only stop at every third or fourth floor, except for one elevator for people with disabilities and that service people who have disabilities. Design and aesthetic interventions, for example, putting music and art in stairwells, designing stairs so that you can see them when you walk into a building and you can find them easily, and they feel more safe because they're clearly visible right from the entrance. Natural lighting appears to be important as well in some of the studies that I've been involved in. Anyways, all this to say that opportunities for daily activity are extremely important. And I think you may ask the question, what can a little bit of stair use do? Well, physical activity experts who calculate caloric burn actually have shown that, if the average adult was to climb just an extra 2 minutes a day, we could actually burn enough calories in those adults to prevent average annual weight gains that we're seeing in adults. The other is there's a Harvard alumni men's study that followed over 10,000 men over a 13-year period. It was a cohort study, and they found that the men who climbed on average 20 to 34 floors of stairs per week, if you divide that by 7, that's only 3 to 5 floors a day, they actually had a 29% reduction in their risk of stroke over that 13-year period. And that was independent of whether they exercised in their leisure time. So these daily activities that we incorporate into our daily lives can actually make a difference in weight maintenance and also in prevention of chronic diseases like stroke. Next slide, please. Social support mechanisms are also important in the community. So for example, interventions that are actually undertaken, like walking groups, buddy activities, groups that provide friendship but around a physical activity, physically active activities, have been shown not only to strengthen social networks, but to also increase people's physical activity and help them maintain physical activity. Community health workers that have been models have also been shown to improve outcomes like blood pressure, cholesterol, triglycerides, and blood sugar control. Next slide, please. And then settings. We talked about settings earlier. So settings like our work site, where we spend so much of our time. I think often, if we're doing some sort of initiative in our work setting, we're providing, as I said, things like, written materials like brochures, or, people might have a website they can go to. But actually, a comprehensive approach that includes the social factors that can affect behavior change, like coworker and family support systems being built into those initiatives, rewards like policies that reward and reinforce healthy behaviors, and then also physical infrastructure and organizational structures that make healthy choices easier choices, where healthy foods are more available, unhealthy foods are less available, opportunities to be more physically active in our daily lives, in our buildings, around our buildings, even how we locate those buildings. Are they in walkable neighborhoods, for example? Are they in neighborhoods that have healthy food stores nearby? Anyways, there are RCTs showing that work sites that have undertaken comprehensive sets of interventions show better weight outcomes compared to work sites that do not. Next slide, please. Oh, sorry, Brenica, next slide, please. Is it jammed? Okay, and then of course for our children, school factors as well, right? Physical education, very important, but not just regular physical education that often has the children sitting there for hours, like for most of the gym period. So there are curricula, evidence-based, that are in the literature that show that if you have better quality physical education, as well as sufficient time for physical education, you can greatly impact children's physical activity levels. So example, there are programs where instead of, for example, during baseball season, when one child goes up to bat, if the child hits the ball, every single child on their team actually has to run the bases, right? So more children are active more of the time for most of the class. So there are ways to improve physical education in our schools. Neighborhood walkability. In other words, how close we locate schools to homes and how safely those homes and residential areas are connected for walking, for example, to school. There are programs like walking school buses, where children are walked as a group with some adult supervision in their neighborhoods to the school. Availability of indoor and outdoor physical activity facilities at the school. Proximity of that school to other recreational activities. So it's easy for children to go from school to after school activities, for example. Design of the playgrounds. There are even emerging literature around how furniture in schools could impact children's caloric burn. So for example, there are furniture now where children can sit and continuously fidget while they're sitting there, right? And by doing so, burn extra calories while they are sitting in school. Standing desks that are smaller but appropriate for children, as you can see in this picture. Meal policies at schools. Even something as simple as providing just water during school lunch, right? So that children can drink water as opposed to, less healthy sugary beverages. And then how we, the programs that provide snacks to schools, are they healthy snacks or unhealthy snacks? Anyways, associated outcomes from this gamut of studies include reduction and maintenance of obesity rates, as opposed to increase in obesity rates over time in children, improved moderate to vigorous physical activity, and even improved academic achievement that are associated with improved health outcomes of these kids. Next slide, please. Okay, and then food retail is another area that we need to think about, right? So studies are showing that if you have availability of healthy food and premises that sell healthy foods, like supermarkets, available in your neighborhood, they're associated with lower rates of neighborhood obesity. On the other hand, you have a high density of unhealthy food outlets like fast food restaurants. It's associated with increased weight and obesity and poor nutrition in both adults and children in those areas. We've already talked about point of decision information like the stair prompt information for physical activity, but similarly, menu labeling, for example, putting calories on menus, point of decision information in our food retail outlets like our cafeterias and our restaurants have been shown to impact people's ability to make healthier choices. Studies actually show that people have a really real challenges in identifying the calories in food, particularly in food that they eat outside. And that includes when studies are done on dietitians and nutritionists. They even have challenges identifying, being able to accurately identify caloric counts. And so information like that are things that we can help to provide for our residents and for our populations in being able to better manage their diets. Trans fat exposure is associated with increased cardiovascular risk. Now in Canada, we recently banned trans fats in packaged foods. Now that comes quite late because this has been done for quite a while now in places like the United States. But in jurisdictions in the United States, like New York, for example, we've also banned trans fats in restaurant food. Now, so the question becomes, is this something that we could do here as well? In addition to the requirement of menu labeling like calories on menus and on menu boards. Gardening, studies show that, people who are involved in gardening may actually eat more fruits and vegetables, and that includes both adults and children. This is particularly strong actually for school children. And so what more can our schools do around community gardening initiatives? And then access to tap water even. So there's actually this one controlled trial in Germany that looked at elementary schools in impoverished neighborhoods. And they actually divided the schools into control schools and intervention schools. And in the intervention schools where they actually ensured that tap water was available, coupled with some education, those schools actually had reduced risk of overweight in the children over time. I'm being asked some questions, which I'll answer later. Next slide, please. Okay, next slide, please. Okay, so some examples of innovations. I just want to demonstrate that all of these pieces of evidence that I've just showed you that are evidence-based interventions can occur in real life. I worked in New York City. I was there for 12 years. And I'm going to show you some of the things that we were able to achieve and some of the results we were able to achieve. Next slide, please, Veronica. And I know we got to finish up. Here are some examples of settings-based approaches. So in New York, one of the things that we did was actually introduce new daycare policies that required food and beverage standards in every daycare. It limited the amount of TV viewing allowed to 60 minutes or less daily. And it required all daycares to provide at least 60 minutes of physical activity daily to their kids. Now, our public health inspectors already go into daycares, right? They go into daycares here as well. But primarily, prior to these standards, and in most jurisdictions, including our current jurisdictions, health inspectors, when they go in, they're checking for safety issues and infectious disease risks. So the issues of the past, not incorporating the childhood obesity epidemics that we're experiencing now. So in New York, we introduced these new standards that required daycares to become healthier food-wise, not just have safe food, but healthy foods and beverages, and increase activity for children. I was actually going to say that the limits to TV is actually also really important. There's actually a whole literature that TV viewing in children, particularly in children, but also in adults, is associated with obesity. And in children, it's associated with obesity, likely not just from a physical inactivity perspective, but also from a dietary perspective. So there's the snacking while you're eating, while you're watching TV, but there's actually also exposure to food advertising during children's programming that causes children to nag their parents for unhealthy foods when they're at the grocery store, that then is associated with less healthy weights in children. School-based surveillance for childhood obesity. So, we actually worked with, in New York, we worked with schools in physical education so that every child in phys ed every year would be measured for their heights and weights. And in so doing, we now had an obesity surveillance system where we could track children's heights and weights. In Alberta, we actually have public health nurses that go into schools to do vaccinations, right? And I'm asking the question, could we also have those nurses measure heights and weights when they're in schools so that we would start to have data on what our children's BMIs are looking like in the Alberta context? Anyways, when children were identified as having high risk of as having weight issues, whether they're underweight or overweight, children would be actually, all children would be sent over a report card, and then children who were identified in the screening in New York as underweight or overweight, their parents would be asked to take the children in for an assessment with their pediatrician or family doc, to follow up. And then, of course, other things like school lunch improvements, physical activity improvements, both from how they constructed schools, but also, for schools that didn't have enough space, actually working with transportation to allow for play streets as additional areas that children could use for lunchtime recess and for phys ed and for to play on next to the school. Next slide, please. Okay, so I wanted to impress upon you that, many of us work in healthcare work sites, in government work sites, and academic work sites. And these work sites could really function as demonstration sites for what could be healthy. Do we have, water bottle refilling stations? Are stairs usable and pleasant and safe to use? Do we have things like standing and treadmill desks? What are our food policy standards and our construction standards in terms of health promoting features in these buildings when we're renovating, when we're building a new building? Next slide, please. I wanted to just call out as well that there is a need to address this in our aging populations and high needs, low income populations, vulnerable populations, right? So do our affordable housing buildings, can they actually be improved to ensure that there's recreation spaces for the populations that can least afford to join a gym or to put their children in recreational programming that might cost money? And that's been done in a whole host of case studies that you'll find if for example, if you're interested to read about some of these case studies of the affordable housing I've been involved with in New York City in the Fit Cities book. There are ways to actually work with planning and economic development and city department to create zoning and tax incentives for supermarket development, for example, in our food desert neighborhoods. In New York, we even introduced like new street food carts that were actually fruit and vegetable carts rather than unhealthy hot dog carts. Next slide, please. And like I said, our healthcare sites as being demonstration sites for healthcare for healthy designs and amenities. And if our healthcare sites are actually located in a neighborhood that's a food desert, that's located in a neighborhood that doesn't have any safe parks or playgrounds, can our healthcare sites themselves become community resources? Can we put a walking path right into that neighborhood? Can we put a playground right onto our grassy areas? Can we create some gardening areas? Can we bring a farmer's market every week onto our own healthcare sites so that that community, which is a food desert, which is a physical activity desert, could actually benefit, as well as our own staff and patients and their families? Next slide, please. Okay, and then this is just to say there's a whole host we could do. I'll let you look at this yourself. I've already talked about we can introduce new standards for labeling of menus and menu boards in our restaurants, like putting calories onto them. banning trans fats and unhealthy ingredients. These are all things that have been done. They've been done in New York. They've been done in other jurisdictions during the time that I was in New York, or after New York City's tried some of these things. A whole host of other jurisdictions have picked this up, and we could be doing more of that in Alberta as well. Next slide, please. Okay, and successes in New York City include reversals in childhood obesity trends, increases in physical activity like bicycling, at the same time decreasing traffic fatalities. Transit is actually associated with walking, because often when you take transit, you're walking to the transit stop, and when you get off transit, you're walking again. And so increasing transit ridership is actually often good for physical activity and walking as well. We were able to show significant declines in physical inactivity during the decade that we did this work, and increased life expectancies as a result of improved chronic disease outcomes. And we didn't do that by negatively impacting economic outcomes. In fact, wherever we pedestrianized and did increase bicycle lanes, we actually worked with transportation, and they worked with, for example, the businesses in the local areas. And we were actually able to show that those were actually good for businesses, as well as things like tourism. Next slide, please. Anyways, if you want to read about it, just go to my website. You could find some of the resources. I also offer a course at Columbia University called Designing Healthy Cities. If anyone's interested in spending 2 days in New York City, once we open up, so it may or may not occur this June. Next slide, please. Anyways, just to let you know, in Alberta, there is this current initiative called Housing for Health that I run. We're trying to recreate the processes by which we had the successes in New York City. If people are interested, please contact me or this Housing for Health email, h4h@ualberta.ca. It's got this huge partnership of different sectors, including the planning community for multiple municipalities, including City of Edmonton, not just academic sectors, but community resident groups, for example, that are interested in these issues across City of Edmonton. We're working together to create a set of healthy community guidelines that Alberta communities can start to use. If you're interested in being involved, we do have physicians like geriatricians that are involved. Do join us. We've got some pilot developments to try and do these things in Edmonton and in Whitecourt, Alberta. So smaller place, larger city. There's a whole community engagement component. We are doing research on how this is going to impact health, and particularly obesity, physical activity, social connection, and healthy eating outcomes. And we have our first annual conference coming up that I hope you can join. Next slide, please. And this is the conference. The new updated slides actually has a direct link to the registration page that you can click on if you download the PDF of the presentation after this. I hope you'll join us. We have an early bird registration of just $10, half price until February 12th. So until the end of next week. Next slide, please. And if you're interested in learning more, there are stories in the book, but there's also this website, drkarenlee.com. If you go to the resources page, there are peer-reviewed publications there. There's also additional free resources of all the different types of guidelines and guides that I was involved with when I was in New York City. The course at Columbia, and then at U of A, I'm talking to the Faculty of Extension about creating courses and future webinars. If people are interested, do let me know, and we can get you some dates when those are ready. Next slide, please. Lots of other references as well that you could take a look at. Next slide, please. I have my resident to thank, so Dr. Alina Levtiak, who's a fourth-year public health medicine resident. She helped me on some of the aspect of this presentation. She's also working with Dr. Renika Modi. We're actually working together to see if we could create a new obesity medicine fellowship right here in Edmonton. And I also want to thank, the Housing for Health initiative has been made in part possible from funding from the Public Health Agency of Canada through a grant. Next slide, please. And let's go to questions if there's time for that, maybe for one or two.
Yeah, I think.
Thank you, everyone, for your patience and for attending this presentation.
All right. So this is a question from Dr. Kwan. Are you consulted in Edmonton City planning, and are there any initiatives you're involved in right now for Edmonton?
Absolutely. So the Housing for Health initiative, as I mentioned, the City of Edmonton actually has multiple departments involved in that. Their urban planning group is very involved with us. In fact, the conference that we're about to mount on February 24th, the Fit Cities, Fit Towns conference, there are a number of City of Edmonton folks from their planning department who are part of that planning committee. We're also working with them on, for example, the City of Edmonton just launched a new master plan for the city called City Plan. It's just been adopted by City Council. And the master plan, or city plan in our case, actually is going to guide how we develop and grow over the next few decades. And so one of the things that I'm really happy about is, since I came back to Canada, to Edmonton in 2018, I'm originally from here, I went away, and then I came back in 2018, I've been actually working with the group that has been creating City Plan, and they now have 4 key strategic pillars in City Plan, 4 key strategic goals. And I'm really happy to say one of them is actually a healthy city. And so the next phase for them is to actually implement initiatives, including, for example, they're doing a zoning bylaw renewal that will implement this vision going forward. So the Housing for Health initiative that I mentioned to you, that is currently funded by the Public Health Agency of Canada, we have this partnership that includes City of Edmonton, but it actually also includes City of Lethbridge, folks from Calgary, folks from, Wood Buffalo, like, the areas around City of Edmonton. So our region, like Sturgeon County, City of Beaumont. So there are multiple, City of St. Albert. So I was going to say, there are these municipal officials and planners who are involved with us. And I would say that, we have some physicians involved, but we could use a lot more physicians. So if you're experiencing things that you want to give input to these people for, please join our Housing for Health partnership. Sorry. Go ahead, Ranika. Another question?
Yeah, we have one more question. Do you address cold climate, for example, ice on the sidewalks?
Yes, we are. Yes, and that comes up a lot, especially for, vulnerable populations like older folks. We do. So I do that from both a research perspective, but also from using that research to try to influence, policies and practices by those outside of the healthcare sector. So people who maintain the roads, like our public works and transportation departments, people who might design new sidewalks. So I'll give you an example. The pilot developments that we're working on, the one in Edmonton and in Whitecourt, in partnership with a developer and the developer's teams, one of the things being discussed, because the developers' developments actually target aging populations. So one of the things being discussed is actually whether it might be possible to make the sidewalks on that development more innovative and more conducive to older people walking on them in the winter. So one part, of course, is just merely clearing that sidewalk by shoveling and brushing those sidewalks, clearing them of ice and snow. But another is, more innovative design and technologies that can be applied. For example, Could we put railings on sidewalks, particularly their areas that have more seniors? There are new technologies like that will allow you to heat the sidewalk so that they don't actually require clearing in the winter and they'll stay ice and snow free. So we're exploring design considerations like railings and heated sidewalks, for example, with the developer. We are also, of course, involved in research. So one of my master's students, for example, did a photo voice research, where he gave cameras to older adults across different parts of city of Edmonton. And he asked them to take pictures of things that would impede their ability to be healthy. And so it's very interesting. And then he did focus groups with them on these pictures. And the older adults actually showed things like, huge puddles of water, for example, during spring and after rains that would clog up the corners of crosswalks, right? And so people who had canes or that had some troubles with mobility would then not be able to actually cross the street because of these puddles that would occur after snow melts or after rains. So better engineering is needed at those crosswalks. And also, there are other ways of addressing that. Like, for example, there are cities that have raised crosswalks. And so we're trying to share those results with our developer partner, with our municipalities, so that they can make improvements. And we're doing that also through these healthy community guidelines, trying to incorporate evidence right into them to be used routinely by municipalities and developers going forward.
All right. I think there's just a nice comment here. We're just talking about kids and COVID and the orders to stay home and kids not being as active as they, used to be. They're on electronics a lot. And then someone mentioning that Grand Prairie City Councilor spent a day as people with mobility issues in their city developed a plan to make the city more accessible. Yeah. So Karen, just for the sake of time, we're going to wrap that up right there. Thank you very much for joining us.
Thank you for inviting me, Ren.
Yeah, for sure.
Thank you. I can hear one clap. Thank you.
We are troubleshooting here. So I'm going to get you guys all. So Bibi, are you going to put into the chat box right now? So spend a minute, go into the chat box, hit the button or the link, and go and do your evaluation, please. All right, let's move along and see if we can catch up a little bit on time. So our next speaker is Dr. Clinton Logan. Dr. Logan is joining us from Calgary. Dr. Logan is originally from northwestern Alberta and has lived around Canada in Quebec, Ontario, Alberta, and British Columbia. His wife is from California. They lived in Portland, Oregon, where he attended Portland State University and graduated with honors with distinction with his Bachelor of Sciences degree in Public Health and with studies in nutrition. He attended medical school at the Medical College of Wisconsin in Milwaukee, Wisconsin, and chose to return to Canada to attend residency in family medicine at the University of Calgary. Currently, he divides his professional time between a busy family practice and working at the Calgary Weight Management Center, seeing patients who deal with obesity and eating disorders. He has a passion for compassion regarding patients who deal with obesity and says that he finds working at the Calgary Weight Management Center to be very rewarding if it wasn't for all the charting. Dun, dun, dun. His home life is spent usually with his wife and 2 young daughters. I welcome Clinton Logan, and I wonder who's his favorite NHL team? Okay, Quentin, take the platform.
You must not know me very well because, can you hear me, by the way?
I can hear you, Sabrina.
Perfect. No, I was going to say you must not know me very well because people who know me know that I don't pay attention to sports whatsoever. So I don't really have a favorite NHL team. I'm sorry. But if the majority of people are watching this from Edmonton, maybe I should say the Oilers, I guess. But anyway, here we go. Let me just take control of the screen here again. So my main topic was about the diagnosis and assessment of obesity. While I was reviewing my slides here last night, one of the things I noticed was that I covered quite a bit of topics, more than just within my own range. So I might be able to save time here by just kind of skimming over some of those slides here at the end, but I'll still cover them here. For any disclosures, as you can see here, I did once do a panel for Novo Nordisk, but aside from that, everything else, I haven't been paid by anybody to present this this presentation here. All right. I think every once in a while I'm losing control of the screen here. Just for mitigating bias, obviously, one of the things we did was we sent out surveys to try to ask people what kind of things that they're interested in for this conference. And so a lot of these topics are actually coming from that. And then as well, a lot of my talk here is actually coming from the updated obesity guidelines. And I took a review of them just the other day just to make sure that everything was still up to date. A lot of these slides were presented or were prepared back last year. Okay, so the objectives that we see here, basically the idea is to try to assess the impact of both physician and weight bias on the doctor-patient therapeutic relationship. And this is actually one aspect that I'm very interested in. Hopefully that will kind of present itself as I go on here. Apply classical chronic disease management approaches to obesity. Basically, we're just going to try to point out that obesity is more than just a behavioral issue. It's much more complex than that, unfortunately. If obesity was purely a behavioral issue, I could tell you right now that the majority of patients who deal with obesity would not deal with obesity anymore. The whole issue with obesity is that it's much more complex. The whole idea of let's just have you eat less and move more, and that will turn around the obesity. Many of you who might have experienced this already probably know that that doesn't actually work very well long-term in practice. And then we're going to talk about BMI, its limitations, the Edmonton Obesity Staging System, and then we're going to talk about how much weight loss is needed to actually cause some weight improvements in the first place. Okay, so the first question is this one. Which statement below would be an appropriate way to start a conversation about weight? I'm going to try to open this poll here. Let me just change the right questions here. Okay. I believe you can see on your screen now the question there. One of the things you'll notice is that there's more than one question there. Just answer that top one, the first question there. I'll give you about 10 seconds to do so. 5, 4, 3, 2, 1. Okay, I'm gonna close up the poll. And I think I was told to we're going to be going over these results at the end of the talk, right? Okay, sounds good. But basically let me just minimize this window here. Basically, the answer here hopefully was relatively obvious. Number one, you've gained a lot of weight lately. That's not really inviting, or that's not really asking the patient any permission to talk about weight. It's just assuming that they're wanting to talk about weight, which isn't really the best approach. You're starting to get obese. You should do something about that. If you're under the impression that patients don't have mirrors, then in this case, obviously, a lot of patients are fully aware that they're dealing with weight. So trying to just point it out to them when they weren't even expecting it is probably not the best approach. Your blood pressure wouldn't be so high if you weren't so heavy, you know. Patients are already well aware of that. That last one there, hopefully it was relatively obvious. Would you mind if we discussed your weight? It would be the best way to approach it. You might think of more tactful ways to do it, though, to be honest. So that's number 4, I said, is probably the right answer there. So weight bias, this is mainly just, the first part of this slide is obviously just talking about what is weight bias in the first place. Often it just means stigmatizing patients because of their obesity and applying stereotypes to a person because of their obesity, which translates into unfair treatment, basically. I actually just wanted to mention an article that I would really encourage you to read if you get a chance. If you Google this title, "Everything You Know About Obesity is Wrong," it's by Michael Hobbs. It was published on the Huffington Post website. So again, if you want to read that, and I would really highly encourage you to read this, "Everything You Know About Obesity is Wrong." I just checked it out the other day. It's still up online, so you can still take a look. If you end up reading the article, the start of the article starts out very interesting. It kind of just starts with some history, and I'm just going to kind of really quickly summarize that because it launches into a lot of these topics. Believe it or not, he actually starts talking about obesity by talking about scurvy. He says that in the 1600s, scurvy was very common, especially with the world being explored, but nobody knew the cause at the time. Lots and lots of cures were tried, including some horrific things were tried. And then in 1747, a British doctor named Dr. James Lind, he did an experiment, and he took on board one single ship. He divided the sailors up into groups, and he said, that group is going to get seawater once a day, that group is going to get vinegar, this group is going to get cider, and this group is going to get citrus juice. And I think it was within a couple of months, the results were obvious. The people on the citrus juice were doing significantly better than the people who weren't on citrus juice. And so despite this, Dr. Lind published his results, but his results were not being put into wide use until about another half century later. We saw the same issue with seat belts, actually. Cars were being mass produced in the early 1900s. Seat belts weren't really being introduced until about a half a century later. Asbestos was recognized as a cause of death in 1906, but same issue. We didn't have any laws banning the widespread use of asbestos until the 1970s. And in that article, and a lot of this is coming from that article, the author says, every discovery in public health, no matter how significant, must compete with the traditions, assumptions, and financial incentives of the society implementing it. So today, probably one of the biggest public health issues that we're seeing is that there's a big knowledge action gap when it comes to obesity itself. One of the purposes of this talk, as well as the whole conference in general, as well as the new obesity guidelines, is to try to update people and say, this is what we currently know about obesity. This is what some of the research is showing us. And then hopefully, as we go forward, the attitudes towards weight and obesity will be changed. I can imagine that for many of you may have talked to patients who deal with obesity or colleagues or that kind of thing, where patients who deal with obesity are feeling the stigma against them, and it's not just on the street or in their families, it's especially within a healthcare setting. Again, that's what that article is about. And the author of that article said, I've never been in an interview with people I was interviewing where they would shake with rage while telling me the stories of their interactions with their doctors, or where they would cry the entire way through. A lot of the people who we interviewed didn't even want to be mentioned by name or gender or age or anything that could possibly identify them. They were so afraid of their doctors finding out that they had interviewed for this article. So in other words, I'm just trying to indicate there's a major weight bias, and it is present in healthcare, obviously. You can see on that slide there, the second point down, in a survey of physicians, obesity was associated with poor hygiene, non-compliance, hostility, and dishonesty. And over a third of family physicians often would describe patients with obesity as lazy. And then another just added point there at the bottom there have been widespread reports of some physicians delaying or withholding pelvic exams purely due to the patient's weight. I was also kind of shocked to find out that in a survey of gynecology practices in Florida, about a fifth of them refused to see female patients that were over 200 pounds. And it was on their criteria. You weren't allowed to refer to them if your patient was over 200 pounds. So patients who deal with obesity are seeing a harder time finding preventive care, and they are being ignored by some people within the healthcare community. And hopefully not by people who are watching this, but just I'm sure that many of you already realize that exists out in the community. All right, let me just take. So trying to mitigating weight bias, first of all, acknowledging it exists, just like every other problem, where you first have to acknowledge that it's a problem. just acknowledging that it exists. The second point there, not all obese patients want, and that actually should be, not all patients who deal with obesity want to talk about weight loss. Do not assume that this topic is open for discussion. Many patients, by the time they've seen you, have already seen many doctors or many clinicians who just outright come out and say, I think you're fat. And so now they're not really open to the idea of discussing it with you. There's a saying of people don't really know how much you, people don't care about how much you know until they know how much you care. And so in this situation, sometimes you actually have to kind of warm up to the idea before patients will be open to talking about it. That third point there, creating a weight-friendly environment, such as using chairs that are specific to them. One thing to think about is actually right now I'm in a chair that has arms on it, but patients who deal with fairly high weights, that's not going to work for them. So you have to be cognizant of that when designing your office. In some rooms, if you walk in and you notice that the patient who deals with obesity is standing and seems to refuse to sit down, that could be one of the reasons the chairs just aren't adaptable. Scales ideally should be in a place away from other people's eyes. And then regarding blood pressure cuffs, I was once locuming at a practice, and I was seeing the patient who was dealing with weight, and I needed to get a blood pressure. And so I went to go grab the blood pressure cuff, and the patient said, oh, that one's not going to fit me. And I said, okay, let me just go find a different cuff. Notice how I didn't say the larger cuff. I said, let me go and find a different cuff. So I went and searched for that, that big red one that a lot of offices have in it. I went on a search for that one. I couldn't find it. And so I had left the door open as I walked out of the patient's room. And so they could probably hear everything that was going on out in the hallway. But I said to one of the staff who was there, do you know where that red blood pressure cuff is? And she said, oh, the one for fat people. So imagine how that patient feels. They're sitting in the room. They can hear all this going on out there. That's not a very weight-friendly environment at all. The other thing, the fourth point there, when discussing obesity, emphasize its complex pathophysiology involving genetics, physiology, and environment. I think most of the patients that I talk to about obesity, I think they get the impression, well, I hope they get the impression anyway, that they're not going to come in and I'm going to wag my finger at them and say, oh, you had too much pizza, or you had too many Cheetos, or you're not active enough and this is all your fault. Mostly because once you actually emphasize how weight actually works, they kind of get the impression that this is much more complex than I just eat too much and move too little. Genetics comes heavily into play here. One of the things that I was actually taking a look at last night, height is considered to be about 80 to 85% genetic, which means you can inhibit somebody's height if you feed them very poorly. They can't quite reach their full potential of their height, even though it's 85% genetic. So the question is, how genetic do you think weight is? And the answer is, we're not 100% sure because we haven't discovered all obesity genes, but it's probably somewhere in the range of 50 to 70% genetic, which means it's not lagging that far behind height. And as well, if you've ever done those, I can't remember what they're called now, those genetics tables. Anybody who's been in genetics is probably screaming at me right now. But those genetics tables where we take the mom and dad's chromosomes and anyway, when we take both of their chromosomes and you put them into one of those 2x2 tables, what you'll usually see, oh, there we go, Mendelian Punnett square. Thanks, Dr. Kwan. But what we usually see is even though obesity is probably caused by caused by many genes, but we still do see a little bit of the distribution that we typically see with other single gene traits. So a lot of people will say, I deal with obesity, but for some reason I have two sisters that are bone thin, and then I have a brother that's maybe just a little bit heavy. But the point is that this is significantly genetic, and once you acknowledge that with a patient, I think they can kind of realize that it's probably not it's not entirely their fault. So again, just watch your language is one of the things that's written there. So these are the 5 A's of approaching obesity. Number 1, ask for permission. if you work in a weight management clinic, I think that's kind of implied when they walk through the door that you might be talking about weight that day. But in a family practice, please don't just come out and say, "Hey, I think you're too heavy. I think we need to talk about it." That's not really the best approach. Number two, assess obesity-related risks and root causes of obesity. One of the things you have to consider here, anybody who's worked in psychiatry will tell you, you have to consider what was the developmental history like. Did they reach their milestones? Were they exposed to anything in utero? But as well, what was the home environment like? Were they exposed to any adverse childhood events? What were the parents like? Were they exposed to diets when they were growing up as a teenager? Were they exposed to teasing? And then especially once they get to university, one of the common things, sadly, one of the common things that we encounter, especially among females who are dealing with weight, is a history of things like sexual abuse and sexual assault. So all these things do come into play. So these are things that are appropriate to ask about when it comes to a weight history. Maybe not on the first visit, but oftentimes patients will kind of reveal this to you as time goes on. So in other words, it's highly multifactorial, and many things that you might not even think would apply do apply. Another thing that's actually very important to ask about is their diet history. One of the reasons I like to ask that question is because you'll notice a trend. Most patients will say, the first time I went on Weight Watchers, I lost tons of weight, but then the second time maybe a little less, the third time maybe a little less than that. And then before long, it's one of the things you'll notice is that by the time you're attempting your 100th diet, it's significantly harder. And that's mainly just because the body adapts to lower calorie intakes. So taking a diet history is actually very important as well. I was looking at a website the other day, and it was just a website of people who are heavily into fasting, like even prolonged fasts, like days at a time. But one of the reason that they love it is because they take their before and after pictures, and they'll see them at the beginning, they might be a higher weight. And then within a month or two, they all of a sudden very slimmed down and that kind of thing. And so it looks very attractive as a good approach to weight loss. But one thing to notice, and I've told a lot of patients this, is how old is this person? Because if it's their first time really trying to lose weight, you can generally lose weight fairly quickly. But if somebody is 60 years old and has a long history of dieting and tries to do a prolonged fast or that kind of thing, and I'm not promoting fasting as an approach, but if somebody tries to do that approach, then it's probably not going to work nearly as well for them as it would have if this was their first attempt at dieting. The next thing, they're advised on health risks and treatment options. So I'm not a very paternalistic doctor, I have to admit. I'll usually just approach patients and say, these are our options. These are some of the things that are available in the community. And we'll talk about the pros and cons of each one. And then unless one of them is obviously contraindicated, then we'll say, maybe let's agree on a plan here. And that's the next point there, agreeing on health outcomes and behavioral goals. One of the things to be very well aware of is that a lot of patients will come in with pretty lofty goals of their weight loss. So if a patient comes in who's dealing with a weight of 350 pounds and they say, well, when I was 18 years old, I was 120 pounds, that has to be something that you might want to address, only because you don't want the patient making a very lofty goal, hoping to lose over half their weight, and then 3 months later comes in and says, well, I've only lost 10 pounds. This is terrible. But the problem is that their expectations might have been a little bit out of line with reality. So it's actually best to maybe start with very small goals and then see where you get from there. And the last thing, assisting in accessing appropriate resources and providers. And that's kind of part of the discussing what resources do you have in the community? Like, is there a bariatric clinic that they can be referred to? Or what medications are available? Or what do we have within our own clinic? Is there a psychologist? Or is there somebody who can help me with diet, that kind of thing? I realize I'm probably talking a bit fast. I'm mainly just trying to get through time. Question number 2, this is just a true-false question. This might be obvious by now. Obesity is only a lifestyle issue, not a chronic disease. Is that true or false? So I'm gonna relaunch the questions here. Actually, I'm seeing that relaunching the poll will clear existing polling results. Do I want to continue? I'll just go ahead here. Obesity is only a lifestyle issue, not a chronic disease. We'll just give you some time to say whether or not you think that's true or false. I'll give you about 5 seconds here.
Okay, so I think we're gonna tell everyone to keep that poll open now, answer
Okay.
the second question, and just move that box to the side, like just minimize it to the side a bit off your screen so you can keep going. So just answer the questions as they come up, and then are we just gonna review them at the end of the presentation? What we'll do is we'll share the results at the end.
Sounds good.
So don't submit them and don't end the polling, just shift it to the side for at least this presentation. We're working through some glitches here.
Sounds good. Okay, so I'm just going to show the answer here.
And just answer one again, yeah.
Okay, so yeah, that would be my answer on that one. Oh, sorry. There we go. Okay, so what is a chronic disease? This is according to the Canadian Medical Association press release in October 2015. They defined a chronic disease as something that decreases life expectancy, impairs normal function of the body, and can be caused by genetic factors. So this next slide is basically showing these are some medical issues that can be related to obesity. If you read through those, I'm guessing for many of you, a lot of these may not be that big of a surprise. But one of the things that you might notice there is the cancer on the right-hand side. Fat cells, especially when they're larger, can assist in producing some estrogen. So there's a higher amount of estrogen flowing through the blood, which can lead to things like endometrial cancer and potentially breast cancer as well. But as well, obesity has been related to colon cancer, kidney cancer as well. So there are other aspects of where obesity can impact health. This slide is mainly just pointing out that as the body mass index increases, both life expectancy and the number of healthy years decrease. So both of these are comparing either a female or a male, age 20 to 39 with a normal BMI as compared to them. How do patients with obesity fare when it comes to lifespan itself? So class 1 obesity, obviously, there's a shorter lifespan, and then with class 2 and 3, it's a little bit shorter than that, and it's a little bit more pronounced in males, as you can see there. But then the number of healthy years, or you might want to say the number of quality years, drops even further. And by quality years, we basically mean just because you live to age 90, it doesn't mean the last 10 years of your life were blissful. So the number of quality years can drop as well as a result of dealing with weight. And it's a little bit more drastic with the higher classes of obesity there. So the Canadian Medical Association has given some definitions. Obesity is a chronic disease requiring enhanced research, treatment, and prevention efforts. Basically, they're setting the pathway and saying, this is something that deserves a lot of research. And as well, we don't fully understand this whole topic. I was glad to hear Dr. Lee's talk there about the public health aspects. One thing, well, actually, as was introduced at the beginning, I did my undergrad degree in public health, and one thing that people in public health love to tell people is that the majority of the extension in our lifespan has come from public health efforts. So you may not realize this, but the majority of us don't need an ECMO machine to make us survive throughout most of our life, or like a heart-lung machine. Most of us don't require drastic healthcare measures until the very end of our lives. So the majority of that lifespan extension is not coming from brand new surgical technologies or anything like that. It's mostly coming from things like public sewage was a major aspect. Vaccines were also major when it came to extending our lives. A lot of the aspects that, like Dr. Lee is talking about, as well as dietary approaches, trying to reduce trans fats in the community. All these things are actually playing a major role when it comes to extending our lifespans. And so the Canadian Medical Association is just trying to say, this is something that requires a lot of research and intervention here. World Health Organization is basically saying similar things. And then Obesity Canada is also saying obesity is a chronic and often progressive condition, and not unlike diabetes or hypertension. And that's something, actually, I use that analogy a lot with patients, trying to emphasize that weight works a lot like blood pressure. So what I mean by that is nobody says, oh, look, my blood pressure is high. My doctor gave me an ACE inhibitor medication to lower my blood pressure. I'm going to take one tablet and then I'll be cured of my blood pressure. nobody thinks that way. We already know that when you go on blood pressure medications, the blood pressure falls down a bit. It finds a new normal. Even though you're on the medication, it doesn't keep dropping down to zero. It just finds a new normal, stays there as long as you're on the medication. And then one day, if you go off the meds, the blood pressure will start coming back up and will often go back up to its set point where you first started. And so we actually see the same thing with weight. A lot of patients are under the impression that if I go on this diet, I'm going to go from 300 pounds, I'm going to drop back down to 150 pounds, and then I'll never have to worry about weight again. But obviously, that's not how blood pressure works, and that's also not how weight management works, unfortunately, either. This is something that doesn't have a one cure. It basically means that once you deal with obesity, we do have to treat it chronically. Chronic diseases require chronic treatments. All right. Next question. How many Albertans have overweight or obesity? So scroll down to question 3 there.
So everyone should just keep it open now. Now that it's relaunched, go back, answer question 1, 2, now answer question 3, and just keep it open. And then Clinton, we don't have to relaunch it anymore.
Okay, sounds good. I'm just throwing it off to the side here.
Yeah, everyone should just, it's open, answer the first 3 questions now, and then keep it open, shift the box to the side, and then everyone should just keep it open and answer the questions as they come up. And then you can share their answers, Clinton, on your slide deck, and at the end we'll show what everyone else thought the answers were when we share the results at the end.
Sounds good. One of the things I'm seeing, and somebody commented, is that they said that they kept the poll open, but it's still erased, and that's what I'm seeing too on my results. But I can tell you, the last 2 questions everybody answered correctly, 100%. So good job. So I'm just going to throw this poll question off to the side here as well.
Yeah, and everyone will just keep it open now. Yeah.
There we go. We're starting to get some answers, but most of what we're seeing is a lot of people are saying 5 out of 10. And then there's a lesser amount that are saying 7 out of 10 Albertans are dealing with overweight or obesity. And so I'm just going to continue on. In this case, this was based on one resource that I'd found that was saying that it's, let me get this to work, 7 out of 10. But you're going to see on this next slide, there is a contraindication, or sorry, not a contraindication, a contradiction. That last point there. Now, this was according to an updated Health Quality Council Alberta Satisfaction Survey. This one said 6 out of 10 people in Alberta have overweight or obesity, so I apologize for that contradiction there. But an interesting point there, more males than females have obesity, and that's true. That's definitely true in Alberta. And as well, we also see higher obesity rates in rural areas. I grew up in a very rural area, and one of the issues out there was that where are you going to walk? There's nothing around you other than fields. So I guess you could walk to the next power pole. But the other issue too is imagine if you work all day and you get home in the winter at night. So now it's 5 o'clock at night, everything's dark. Are you going to want to walk outside at 5 o'clock at night when everything's dark and there are animals out to get you? But anyway, so these are things that we have to consider. People in rural areas may have a harder time participating in physical activity, even though they have tons of space around them. Unfortunately, a lot of them are commuting to work, and they actually have less time than a lot of people who live in the city. Anyway, I'm going to keep on going here. How much time do we have? Oh, I'm getting close here. Well, actually, I'm over time. What are the best measures to assess obesity and associated risk? If everybody wants to just pull open that poll there. What kind of things there do you think are the best way to assess a patient that might be having risks of obesity? Don't see any answers yet. I think maybe people have gotten tired of the polling. So I'm just going to just move forward a little bit here, and oh, there we go. We have a few respondents anyway, but yeah, a good rule of thumb is if you have an exam question and there's an answer that says all of the above, if you choose that one, you'll probably get it right 3/4 of the time. So that's the correct answer in this case too. Okay, so body mass index. This was developed by a mathematician, painter, sculptor, I don't know how to pronounce his last name, Adolphe Quetelet or something like that, but basically it's weight divided by height squared. This can be used to try to almost categorize patients, heavily used by insurance companies, but also very much used in research. So some of the considerations regarding BMI. The most important part of the aspect of this slide here is it doesn't really account for muscle mass. There are many people who are dealing with fairly high muscle mass who would be considered in either the obese 1 or obese 2 categories. So it does misclassify patients. Of course, a lot of the patients that we're dealing with may not have that much muscle mass compared to those people, but still, overall, these are some of the pitfalls of BMI scales. And then that last point there within that little subgroup of bullets there, 2 people with the same BMI can have a 2-fold difference in total body fat. It doesn't really account for differences among different ethnic groups. It's not a very good way to assess somebody's health status. Just to give an example of this, if somebody comes into your office who has a BMI of 38, but is currently active and is going to the gym for an hour a day, and then on top of that, they're going hiking over the weekend, that kind of thing, then they're probably going to be more healthy than your patient who has a BMI of 25 who has severe diabetes and had a heart attack last year. And those types, I'm kind of drawing these examples out of real patients that I have. So these are real world examples. And then as well, that second last point there, a 5 to 10% reduction in weight is associated with a major improvement in health. It doesn't necessarily lead to even though their weight loss didn't lead to a new BMI category. So let's keep that in mind, that even though we're often shooting for small amounts of weight loss, just because they haven't left a BMI category does not mean that they're not healthier now. I think that was a double negative, so apologize for that. So assessing obesity and weight-related risks. Obesity, that first category is just basically saying that's what BMI looks like. Those are the categories. The next, another common one that was proposed is to measure waist circumference, just because we're trying to get an assessment of how much visceral adiposity are we seeing, because that has been associated with a higher chance of cardiovascular risks. And then the third point there, assess other related health risks and comorbidities, like by using fasting plasma glucose, that's what FPG stands for, A1Cs, blood pressures, cholesterols, ALT levels, that kind of thing. I'm just going to really go through, skip through that slide. And then as well, this is your Edmonton Obesity Staging System. Many of you have probably heard of this already, but it's trying to stratify people based on medical issues, mental health issues, and then functional issues. I don't love this picture as much as I like this one on this next page. So if you were to Google Edmonton Obesity Staging System PDF, this is the first thing that pops up. Basically, this just gives an idea of what each of these stages look like. One of the things to notice is in this box up here in the upper right, this little gray box, we don't put people on the EOSS that have a normal BMI, like who are a BMI of 24. This is more classifying patients that are dealing with one of the obesity scales, so a BMI of 30 or more. So in somebody who, let's say, I'm just going to choose a category, a 32-year-old male, under that stage 2 box, in a gray box, it says 32-year-old male with a BMI of 36 who has primary hypertension, obstructive sleep apnea. In that case, we would say this person has class 2, World Health Organization class 2 obesity, and is dealing with an EOSS stage 2. So if there's any confusion about the Edmonton Obesity Staging System, I find this to be a really good resource. When I first started practicing in dealing with patients with obesity, I was referring to this all the time, just because I needed some good examples. One of the reasons why the Edmonton Obesity Staging System is so helpful is because, like I said before, the BMI scales, they're helpful, but at the same time, they're not really giving you much of an idea of their actual health status, whereas the Edmonton Obesity Staging System does a much better job of that. I hope I'm not just being biased because I'm in Alberta. But question number 5, what is the minimum amount of weight loss needed to result in health benefits? And let's see, so
Yeah,
there's the questions up there.
People can just go down and answer that question and set it aside.
We're getting the right answer so far. So
So then, Clinton, you're going to give them the right answer, and then they can go back and probably change their answer.
yeah.
This is the best.
I wish exams were like this. Uh, but of the people who answered, the answers coming back is 5 to 10%. Let me go back to this slide here. So yeah, that's the correct answer. There is 5 to 10%. So again, when patients come in and say, I want to lose 50% of my weight, I would be so much happier if I just could get all this weight off. It's helpful to gently try to reset expectations. I'll even say from a medical perspective, from a health perspective, I'm just hoping for this much weight loss because that will significantly improve your health. So anyway, so I mean, the point of that slide is mainly to say, try to keep the goals in check there. The reason for the benefits of a 5 to 10% weight loss, we see a 16% relative risk reduction in diabetes with even a single drop of a kilogram of their weight. There's a reduction in cardiovascular risk factors, improvements in cholesterol profiles, improvements in blood pressure. We see improvements in the severity of sleep apnea, and just in terms of pain and physical function, we also see improvements there too. I recognize now I put way too many animations into this slide, but the point of this was just to say, look how many diets there are. That one that just popped up there, that's the cabbage soup diet. I'm sure many of you have heard of this one before. Basically where patients are putting nothing but cabbage soup for days on end. The paleo diet, the abs diet, apparently we're all going to get abdominal muscles now. Living low carb, the Dr. Phil diet, I'm not sure why he's so qualified. The good calories, bad calories diet, DASH diet, I'm sure we've all heard of before. That one has a lot of evidence behind it. The glycemic index diet, the blood type diet. That's an interesting one, but I don't know enough about it to comment on it, though, to be honest. But and then one of the most recent ones that everybody loves is the keto diet. So question 6, which statement is true? Out of all these, which one do you think is the most true? Weight loss is usually permanent. Weight regain is always due to laziness. Most patients regain lost weight within a year, or low carbohydrate diets are the best ones for weight loss. So that's question 6 there. And we already have a lot of answers, actually. And everybody's choosing the right one. So in this case, option 3 is the best choice there. Most patients tend to regain lost weight. It's not always within a year, but well, if you take a look at this next slide here, we do see a natural history of weight regain in patients. So if you look at the slide, basically what you're seeing is when we compare very low calorie diets versus modified diet plus behavior therapy versus very low calorie diets plus behavior therapies, you can see the natural history of this is to actually regain, if not even go a little bit above where they started. If we view this purely from a survival standpoint, if we could look at humankind and zoom way out and we could see all of human history in front of us, one of the things that we would notice is that we're highly privileged right now. I know that 2020 doesn't make it seem like it, but we're actually a relatively privileged society right now. Many of us are not constantly being threatened by our neighbors that are going to attack us or destroy us. Many of us probably have adequate calories that we have access to. Somebody just commented, too much feast, no famine. And yes, yes, you could say that. But let's envision in our minds that there's two tribes. They don't have to live right beside each other, but there's two tribes. One has kind of their food supply kind of hangs on a thread. So they're going through famines on a regular basis versus another group who never goes through famines. One of the things you'll see is that when this group over here first goes through a famine, they will lose a significant amount of weight. But then as they go through recurrent famines over the course of years, their bodies adapt. They lose less and less weight. Now they're well adapted to famines and they don't lose weight during the famine anymore. Whereas the other group who has never been through a famine is probably not adapted to that so far. Now let's replace the word famines with the word diets. The more diets I go through, for some reason, the harder it becomes to lose weight. And hopefully that makes sense as to why that's happening. Again, the purpose of this slide is to indicate we think that humans might have a set point. So basically what that means is that after you've lost weight, your body seems to remember what weight you used to be. and seems to be trying to shoot to get back up to that number. I know that's not very comforting and it's a bit depressing, but if you were to compare this to blood pressure, we see similar issues. If you stop your blood pressure therapy, the odds is that you're going to go right back to where you started before you were on therapy. If your body temperature is 37 degrees Celsius, and I throw you into a vat of ice water, you already know that as soon as you're in there, you're going to start shivering. The blood flow is going to be starting to get redirected to your core to try to save your temperature. But then as soon as we pull you out of the water and the threat is gone, the temperature should go right back to where it started. This is how the body works, and this is homeostasis. The body likes to maintain a specific weight, which is a bit depressing. Next slide here. So treatment options and their effect. We can see with lifestyle modification, we can hope for a 1 to 5% weight drop with purely lifestyle modification. So when patients come to you and say, I'm trying everything, and I'm exercising, and I'm eating barely anything, but I'm just not losing much weight. Hopefully this slide convinces you, please believe them. And admittedly, a lot of us are seeing patients that may not see the problems in their tracking or that kind of thing, but still, the overall point is that it's much more difficult to lose weight than you would think here. Hey? The point of this slide is just basically to point out, when we look at patients that have lost weight and we're able to keep it off, those bottom 4 points there, the majority of them are eating breakfast. A lot of them are keeping track of their weights at least once a week. I'm not strongly suggesting that's a solid piece of advice. Most of them are not watching a ton of television, and then the vast majority of them are exercising about an hour a day. So when patients ask, what can I do to maintain this weight loss? Those might be some important things. Don't start on crazy fad diets now. And as well, you will have to be active. Exercise seems to be very essential when it comes to maintaining weight loss after the weight is gone. Dr. Waldry is going to be going through this, so I'm going to kind of skip over it here, but basically the overall point is medications can be helpful at maintaining further weight loss than just lifestyle changes alone. And this is showing orlistat at I think about the 4-year mark out. This one is showing how liraglutide does, and so we do see maintenance of further weight loss on patients who are using medications. And then naltrexone and bupropion, we're seeing similar issues. The reason why this study doesn't go out very long is only because that's a relatively newer medication. So what does patient success look like? And I think this is my last slide here. Setting realistic goals and expectations. We really try to focus with patients on their health. I know a lot of patients who will say, I just want to get some energy, or I just want to be able to exercise further. And smart aleck me says, oh, great, we can do that in 2 weeks. Because the truth is, if somebody starts walking today, within 2 weeks, they'll be walking further, assuming no major disabilities anyway. But of course, even though smart aleck me says that, there's a significant portion of patients when you help them realize, oh, look how much more exercise you're doing. They don't care. they're mostly interested in just saying, yeah, but the weight hasn't come off. And that's where you might have to kind of start to reset expectations. I personally feel like it's okay to tell patients, this is what I'm hoping for, and you're already achieving it. Because a lot of patients will be very scale focused, only because we've been so hardwired that way by so much information about weight management in the past. Helping patients understand their values comes into play. The reason why I said that one is because I've seen patients who will come in and say, I want to lose weight because I want my husband to like me again, because prior to that they were being almost abused, like emotionally abused by their spouses because of their weight, and hopefully you can already see that's a deeper problem than just you should lose weight. So trying to meet patients with why they're wanting to lose weight in the first place is very important as well. The end goal here is achieving the patient's best weight. And what we mean by that is, at what weight will you balance out at where you're active, where you're minimizing health risks with your activity and with your dietary aspects, and where you're doing something that you can actually tolerate doing the rest of your life. So if somebody comes to you and says, I want to again, I'm going to go back to that fasting thing. I want to fast 2 weeks out of every month. Hopefully you already realize that's probably not realistic as a long-term approach. So we have to find that happy medium where the patient is okay with with following this specific dietary program, while also being active, and it's something that's tolerable during the rest of their lives. If somebody says, I'm going to the gym 3 hours a day, there's no way they're going to keep that up long-term, unless that's their full-time job. All right, any questions?
All right, Clinton. Yeah, we do have a couple. There was actually a number of questions, and I think colleagues have been answering them, like Dr. Chapelsky, Dr. Walji has been answering, chiming in.
Yeah.
So one of the questions is, do you take medications forever?
Yeah. So we get that question quite a bit from patients, and I find that blood pressure approach to weight management is actually, I feel like that's appropriate anyway. So I do tell patients, if down the road, if one day we want to trial off of medications, that I'm not a very paternalistic doctor, so I do tell patients we could trial off at some point down the road and see how it goes. But I find that about half of patients will start regaining at that point. But it also depends on what did they do in the meantime. Is this a person that solely relied on medications to get where they are? Or is this a person who actually made some significant lifestyle changes to get where they are? The other piece I wanted to mention too, just about that, is when I first started practicing in weight management, I was very stingy with medications. And it was partially just because I felt like I almost dangled it like a carrot in front of them, which I recognize now is the wrong thing to do. But I have seen many times with patients that if it's something that's indicated, trialing a medication, when the patient starts losing weight, the patient will often come back and say, and look what else I've changed. Now I'm going to the gym. Maybe not right now, but now I'm going to the gym. Now I'm actually exercising. I've started to alter my diet as well. Sometimes the medications can be a motivator. So in other words, if any of you are practicing that way, I would say just try it the other way and see how it goes.
Exactly, because they've done a lot of that stuff before, for sure. And then again, it comes down to understanding obesity as a chronic disease, so we need chronic treatment.
Yeah.
Do you take, so this is a question, do you take hip-waist ratio or just waist circumference? I don't know if anyone's doing hip-waist ratio. Are you guys?
I haven't, no. And I have to be fairly honest here. When I first started practicing, I did a lot of waist circumference as well, but I don't do it all the time anymore. And I mean, maybe partially because we're doing everything by virtually now, at least our clinic is a lot of things virtually, but also because I just didn't find it that helpful. And patients often got very embarrassed that first visit. If I just jumped up and said, okay, you grab this and then turn around and we'll do a little do-si-do. And then we're going to measure your waist. That was embarrassing for a lot of patients. So I have to admit, I don't always do it straight away.
Yeah, and waist circumference you typically do between a BMI of 25, 35. After a BMI of 35, it's not as effective or helpful. But there's lots of evidence, right? Waist circumference is associated with increased cardiometabolic risk, BMI is. And I don't personally know the evidence for hip waist. So that's what I'm putting out. I don't know the evidence for hip waist, if it's associated with, comorbidities and health status. And with waist circumference, we don't do it either. That's the beauty of seeing patients in clinic. You can look at distribution, right? And that helps a lot. Yeah. How do you help patients? Clinton, if you have the answer to this question, this is the million. Listen, how do you help patients with no insurance or coverage?
Oh, yeah. So this is a bit of a problem, especially patients that are dealing with psychological history or that kind of thing. Luckily, in our clinic anyway, we've signed up with a shared mental health program where a psychologist comes to our clinic and will see patients alongside me. There's also a lot of primary care networks will have access to behavioral health clinicians. And then what about dietitian? The Alberta Healthy Living Program has dietitians on their side. A lot of PCNs will have dietitians attached to them as well.
And what about people who don't have insurance or coverage for medication, I think?
Oh, yes. Sorry. You mentioned that. I just completely skimmed over it.
No. That actually, you made some really good points to people who don't have access to dietitians and other allied health professionals. Yeah. So without I think this was pertaining to coverage for medications, right? Yeah.
Yeah. Dr. Walji knows this because I work in the same practice as her. I tend to be when it comes to having samples, I really take advantage of those, to be honest. And as well, I find that when patients have been started on a sample medication, they'll if it's helping, then some patients will just happen to find the finances to be able to do this. As well, we can also try special authorization sometimes, and I'll even write in the comments, we're actually seeing a weight loss with this patient. We're reducing their risk of future disease. It would be in your best interest to cover this medication for them. So there are some things that we do, but I have to admit, this is a big hurdle for a lot of clinics, and I don't have a great answer to cover it for everyone.
All right. What is this question? Sabrina's writing. Oh, is there an age?
Oh, I thought you said her writing's terrible or something.
Is there an age where we should be looking at de-prescribing obesity medications? Is there an age where we should be looking at de-prescribing obesity, so taking them off?
And is this mainly for mainly due to risks, like patients with atrial fibrillation, or
just based on age, taking them off medications? If someone wants to clarify that question.
Yeah, because the truth is, I'm not sure. I think the age of patients that I have on these kind of medications probably ranges all the way up to age 70.
Yeah. I don't think age factors into any of the guidelines, the prescribing guidelines, in any of the monographs, in fact. What did Dr. Logan mean when he said that if someone was overweight as a child, that their weight loss had to be addressed differently?
Did I say that? I don't remember saying that, to be honest. But no.
That if someone was overweight as a child, that their weight loss would have to be addressed differently. I mean, I think these are just all individual factors that we look at, barriers, behaviors, childhood adverse experiences. I think that's probably, I mean, we factor everything when we do a weight history and a family history.
Yeah, and that's all I meant really, is just get a full history, not that we have to treat them much differently.
Okay. So you guys, Dr. Logan, do you want to share the polling questions, the answers? Let's quickly go through so people can see what everyone answered.
So the first question there, yes, that's a good approach. Would you mind if we discussed your weight? Try and, again, ask their permission. Number 2 there, obesity is only a lifestyle issue, not a chronic disease. That's false.
Everyone has to scroll down. Yeah.
How many Albertans have overweight or obesity? I kind of contradicted myself there. So I guess we'll say the 5 out of 10 and the 7 out of 10 are probably the closest out of the 2, or out of the 4. What are the best measures to assess obesity and associated risk? All of the above. What are the minimum amount of weight loss needed to result in health benefits? That first one, 5 to 10%. And which statement is true? A lot of patients, after they lose weight, tend to regain it within a year, if not 5 years. I should have said that, actually, but it's very common.
All right, thank you, Dr. Logan. You guys, before we let you go, so I'm just going to take the control back. Please fill out your evaluations. Go to your chat box. Click on it before you go to the bathroom. Click on it. Just fill out the evaluation. We're going to take a 10-minute break. Come back. I was going to say 5, but we'll come back like, I don't know. Let's say 11:25. 7-minute break to try to keep things going. So we'll come back at 11:25. See you back. And the exhibit rooms are all open. Please go join them. All the reps are there answering any of your questions. So those are open, right, BB? Okay.
Calculations more towards the beginning of the talk. So it will be handy if you had your phone with you, like the calculator on your phone, or pen and paper with you. That'll help quite a bit. And then the last thing is the poll. So I have about 14 questions. They've fixed the questions for me so that I can post them one at a time. I'm not going to give a lot of time to answer those polls. So please, I do want participation though. So please answer quickly. If you're not sure, just give your best guess and I will share them and we'll see what people are thinking. Okay, and remember, it's all anonymous, so you don't need to worry that anyone knows what you've answered. So I'll just start by saying, the title of my talk is a little bit misleading, maybe on purpose. I'm not actually sure where this came from, but you cannot address obesity in 10 minutes, obviously. The idea here is more, what can you do in small increments over time? Treating obesity is, it's a marathon. It's not a sprint, or, even not a marathon, because marathons have an end. This is more like the long game that has no end. Primary care is cradle to grave. Really, you're treating obesity as a chronic disease until the grave. So these are my disclosures. These are my disclosure of commercial support. And here's the mitigating bias that's in everybody's deck. These are the objectives. I'm not going to go through these one by one. Just know that at the end, you will be asked whether these objectives have been covered. So you'll see them again, and you can say whether you feel that they have been or not. This is a case that I'm going to be sort of referring to now and then throughout the presentation here. So Mrs. X is, I tried to put together like a fairly typical patient that we might see in our clinic here. The only thing that's maybe not typical about this patient is that our average BMI is probably closer to 50. And so her BMI is a bit lower, it's at 42. But definitely her weight-related comorbidities, the medications that she's on, her job, a sedentary desk job, and as a female having gained weight over pregnancies, these are fairly common situations, I guess, or presentations that we would see. So this is just to present her, introduce her, to you. We will come back to her later. So lifestyle modification is really what my talk kind of is about. It really is the critical foundation. If you think of weight control as a house, and the weight control is sort of the roof of your house, then your nutrition, your activity, your behavioral therapy, these things are the foundation of your house. And so you need a solid foundation to work with your pharmacotherapy, with your bariatric surgery as the other pillars that help to hold up your weight control. Having said that, there's also the landscape or the land on which your foundation is built, and that is also important. And I'll come back to that in a moment. So you're gonna look at this. So this was sort of inserted to get a bit of a chuckle, but actually this is what we've sort of been doing to this point. As Dr. Logan had spoken about, we're really, to this point, a lot of it has been eat less, move more. And this is not helpful. Patients stop listening. One of the things that Dr. Sharma often says, the analogy that he makes is quite meaningful to me. And that is, telling someone that is struggling with obesity to eat less and move more is like telling someone that has depression they need to cheer up, right? It's not effective. It's not helpful. And likely your patient isn't going to come back to you because you haven't given them anything to really work with. So here's my first polling question. Go ahead and read it. And while you're reading it, I'm going to actually put the poll up and choose your answer. So let's go to my question. And I'll give you a very short period for this one because it's not really one that we need a lot of time for. Okay, so it's up. Pick your answer. Good. Excellent. So I'm going to close the poll. I apologize if anyone didn't get a chance to answer yet. And let's share these results. So yes, it looks like the majority of you picked 10 or greater than 10, and there were some that said 1, some 3, some 5. So let's stop the share, and let me just close myself out here, and let's see what the answer is. Oops. There we go. So it is actually greater than 10, which might be surprising to some individuals. That's a really long time to go with a problem and not ask for help. So the action study did demonstrate this. And to me, that really tells me that, people for whatever reason are waiting a really long time. And so you need to open that conversation. And how you open that conversation is very important. So Logan already went over this. Sorry, Dr. Logan went over this. And it's, asking for permission. A lot of people don't understand that. Hopefully he's kind of explained it. The analogy that I would make is, this is a very sensitive topic for patients. If you don't actually struggle with weight yourself, you maybe don't realize how much shame and stigma and discomfort that there is around it. And also, unlike other chronic diseases, weight is very obvious. You can't hide your weight. Whereas things like chronic renal failure or, diabetes even, you don't have a sign on your forehead that says that you have this disease. Whereas with weight, it's just out there and it singles you out as being different. So asking for permission, opening the conversation properly will help you to really get somewhere with your patient. That is very, very important. The next day is assess. So I'm not going to go through all of this because he's gone through it. There's just certain parts that I want to point out. So I think we're doing, in primary care, we're doing a good job of obesity-related risk. I think we acknowledge that. The part where we're maybe not doing as good of a job might be actually looking at those potential root causes. And so when we think about the house again and weight control being your roof, those root causes are like the landscape on which you're trying to build your foundation. And there are certain things that if you do not address them early, that you might find that, trying to do the lifestyle change is going to be a lot more difficult. So what are some of those things? Some of those things would be like mental health would be huge. If they have suboptimal depression, anxiety control, if they have an undiagnosed ADHD, it's hard for patients to do things like looking at their food and looking at their activity level when they can't focus long enough to follow through on a task, right? So mental health is huge. Sleep quality. So if they're not sleeping well for whatever reason, maybe it's sleep apnea that's undiagnosed, maybe it is pain control, they don't have adequate pain control. These are all things that can really interfere with their daytime functioning, and that interferes with their ability to actually make those lifestyle kind of changes and behavioral changes. Advise. So we know the risks and we know the benefits, but I think really where we need work is on offering the options. And that's really what day 2 of this conference is going to cover. And that's very, very important. Oftentimes when we look at obesity management up to this point, it's been very stepwise. So it's like, well, okay, let's try lifestyle first. And if you fail with that, then we'll go to pharmacotherapy. And you fail with that, then we'll go to bariatric surgery. And really, we want to have a more holistic approach where, like Dr. Logan mentioned, you just give all the options. This is the menu of options. This is what's available to you. And it is really up to the patient to decide what they feel is appropriate for themselves at that particular time in their life. So the options, giving of options, I think we can do work there. Agree on realistic expectations and SMART goals. So Dr. Logan did mention this, and there will be a slide coming on this. And then assist on addressing barriers, offering education, referring to a provider. And the one where I think we really are falling down is arranging follow-up. So a lot of the time in primary care, you see the weight maybe when they come in for their annual physical, and maybe there's a brief discussion about it. Maybe it's up by 5 pounds or 10 pounds that year. But then where's the next follow-up? And so like any other chronic disease, you need to follow closely. It also shows the patient, this is important and I'm investing in this. And so you also probably should pay more attention to it and work together with me on this. So arranging follow-up, any other chronic disease, if there's a flare, you follow it more closely. If it's in remission, you can back off. So it's no different with weight, and this is a lifelong thing. So if their weight is going up, you need more attention. If their weight is stable, you've got them down to a good place, then you can back off. You don't have to see them as often. It's no different. So this is opening the conversation. Again, Dr. Logan went over this. The one thing I want to point out here, you can read these yourself. The one thing I would want to point out here, for myself personally, I find these, I still think we can do better than this, particularly the 2 sentences. Would it be all right if we discussed your weight? And would you be interested in addressing your weight at this time? I just find the words your weight as very, still putting the burden on the patient, like your problem, your weight, what are we gonna do about your issue? So an alternative that I would maybe prefer would be, I can help you with your weight. Is that something that you're interested in right now? Or would you like me to help you with weight management? I think that just gives the patient a better idea that, I have something to offer you, because at this point, I think part of the reason why patients wait so long to discuss with their physician is because they have felt that the burden is on them to find a solution. It's their problem, their ineptitude, or whatever it may be, and so they have to solve it. So that's, it is very important to approach things properly. And then this was discussed earlier. So that 10% is really what's going to bring you, 5 to 10% is really what's going to give you some health benefit, but that's not what patients are wanting, right? So, you know, it's good to let them know that all they need is 5 to 10% for improvement. In the case of Mrs. X, you know, her reflux, her her hypertension, and her osteoarthritis, you know, she may only need a 5% reduction to see improvements in those conditions, right? So it's important for them to know that, and to also know that quality of life is important too. And that may not require a lot of change as well. I had a patient the other day that told me she was so happy that she had lost 5%. And for her, the difference was being able to clean herself after going to the bathroom and not. So it doesn't take a lot all the time. So nutrition. This is the eat less part. So when you tell a patient to eat less, how much less are we trying to eat? So here we see the daily breakdown of your energy requirements. And you can see the lion's share of your energy requirement is your BMR. Okay, that's your basal metabolic rate. The next slide will tell you more about that. Look at the gray piece. So that's the thermic effect of feeding. The thermic effect of feeding is the caloric or the energy, I guess you could say, required for your digestive system to actually digest food that you eat. Okay, and it's fairly negligible. I mean, it's not completely negligible, but it's fairly negligible. It's a pretty small amount. And then there's physical activity, which of course will vary from patient to patient. So it can be anywhere from 10 to 30%. In certainly in individuals that have severe obesity, you know, you can expect that their physical activity is fairly low. So when we talk to patients, we really talk about basal metabolic rate, and we don't take into account physical activity and thermic effect of feeding. So your BMR is the total number of calories in 24 hours that a body at rest requires to sustain life-preserving functions. And really underneath there, there should be a little bit of addition and remain weight stable. Okay, so certainly you can eat less than your basal metabolic rate, and that's where you're going to hopefully see weight loss. Or you can eat more than your BMR, and that's where you will see weight gain. So here's my first question. I will get the poll up. Go ahead and read it. And this one, really just guess. Give your best guess, and we'll be quick on this one. So here's the poll. Good, keep them coming. I look like I'm looking off to the side. I'm gonna do this. Look like I'm looking forward. There we go. Okay, so most people have answered, and here's the results. And oh, it's a pretty even split. I mean, I'm guessing most people were guessing. So let's stop the share and oops, stop the share. Sorry. And so the Mifflin-St. is actually the correct answer here. The Mifflin-St. equation is here. Please do not feel like you need to memorize this or write this down. The reason I'm showing it is just to point out a couple of things. So you can see that the equation is actually the same between men and women, okay? The only difference is that men get to add 5 calories and women have to subtract 161 calories. And this probably speaks to the lean muscle mass difference, just generally speaking, between men and women. The other thing that I would point out is the more you weigh, the higher your BMR is going to be. And also, the older you are, the lower your BMR is going to be. And again, that's probably due to some inevitable lean muscle mass loss over time. So here's my next question. I would recommend just getting out your phone, Google MSJ BMR calculator. The first hit that comes up, use that and plug in the values. So she's a 46-year-old female, her weight and her height are there for you. Plug them in and see what you get. And while you're doing that, I'm going to launch the poll. I'll give you a little bit of time here, just so that a few more people answer. Use the internet. Don't try and calculate it yourself. You could try and calculate it yourself if you want to, if you wrote the equation down. It should all come out to the same. Okay, so in the interest of time, I'm going to end the poll here. So I apologize if anyone didn't get a chance to do it. So here are the results. We got a variety. We did get a variety. So let me stop the share. And did I stop the share? And then go back to. Oh, am I still sharing? Sorry. Let's stop the share. Okay. So the correct answer is 1,783 calories. So this is Mrs. X's BMR. This is what she requires to stay weight stable. And remember, we're considering the thermic effect of feeding and any physical activity that she does sort of negligible, even though it may not be, but in clinic, this is what we would use. Oops, what's going on? Okay, so here we go. So now you need to create a caloric deficit, okay? And so a key piece of information that you need here is that 3,500 calories is equivalent roughly to 1 pound. So if you eat an excess of 3,500 calories, you will gain a pound. Excess of 3,500 over your BMR, okay? If you have a deficit of 3,500, then you will lose a pound, okay? Over time, over your BMR, okay? So hopefully I haven't confused that too much. So if you think about 1 week, 7 days, okay, 3,500 extra calories in 7 days is about 500 extra calories per day. So if you're 500 calories over your BMR every day for a week, there's about a pound gained. The opposite is true as well. If you're 500 calories below your BMR every day for a week, that will give you roughly a pound lost, okay? So this is going to factor into our next question. The question is, how many calories does Mrs. X need per day in order to lose 1 pound per week? So I will launch the poll. I don't like your mouse, friend.
I love my mouse. I have carpal tunnel.
So here's the poll. Go ahead and answer. Good. Oh, answers are still coming in. Good, good, good. Okay, I'm going to close the poll. We're trying to catch up time here. So there are the results. Got a little bit of variety, but majority did say 1283. And let's stop sharing, close, go back to the thing. And that is actually the correct answer. So 500 left. Sorry, I should have told you, reminded you that her BMR was 1,783. So 500 less of that per day would be 1,283. So that's how that answer comes. So true or false? Read the question. I'll put the answer, or the poll up, just to interests of time here. Go with your gut. Okay, I'm going to close the poll. Sorry to anyone that hasn't answered yet and wanted to, and share the results. Oh, so 3/4 said true and 1/4 said false. Let me just stop the share and go back to my thing here. And it is actually true. So when you get under 1,200 calories per day, really the intake is not enough to necessarily cover all the nutrients, the vitamins and minerals that you need in a day. And so it is recommended that under 1,200, you do supplement or support with a daily multivitamin. So protein requirement. There is a reason why I am singling out protein requirement specifically and not talking about other macronutrients like your fat and your carbs. So protein is very important. When you're losing weight, we talk about healthy weight loss, or that's what this talk is about. When you're losing weight, you want to make sure that the majority of what you're losing is fat mass, not muscle mass. Because remember, your muscle mass is really what drives your metabolism, what keeps your BMR higher, right? So this is part of why, what Dr. Logan was talking about. When you do a starvation diet where you just literally don't eat anything, you know, you lose, but you're also losing that muscle. And so the protein is what supports the muscle. There's a couple of other reasons. So protein is what I would call one of your natural hunger regulators. Protein tends to make people feel full and keep them feeling full a bit longer, right? And it partially has to do with what happens with your blood sugar when you eat protein, right? So with protein, you get a more gradual rise and then more of a stable period and then a gradual fall. Versus, for example, carbs, where you will get a big spike in blood sugar and then a big crash. And when that crash happens, maybe like a couple hours later, then, you know, naturally you feel more hungry, right? And you feel like you need to eat again. And if you eat carbs again, then you're just on that roller coaster again, right? So there's a few reasons. So protein is very important. This protein calculation that you're seeing here is what our clinic uses. It is quite high. In the community, the dietitian would probably use like 0.8 to 1 gram, so a significantly lower number. So we will do some calculations with this if you want to jot it down, but I'll remind you as well. And then ideal body weight. What is ideal body weight? So the ideal body weight calculation is really just calculating what would their weight be at the high end of the normal BMI range for their height. So using 24.9, high end of the normal range of the BMI, and a height in Mrs. X's case, so it has to be in meters, not centimeters. She's 1.65 meters tall. So go ahead and do that calculation because that is actually the next question. And I'll get the poll up for you. And then the second part of the question is like, what is her protein requirement, right? So you can calculate that using 1.2 to 1.6 and go ahead and answer what you think it will be. Variety of answers coming in, good. I'm going to stop it just because it looks like it's died down. Some people may just have gotten tired of the calculations and aren't doing it. So I'm going to end the poll here. We'll see what the answers are. So there's kind of almost an even split between the last three. And then the last one is actually the correct answer. So D is the correct answer. The other thing I just want to make note of here is the ideal body weight. That is, in my opinion, a bit of a misnomer. I presented this to a colleague just to run through it, and she said, oh, so that's the weight that I want to get my patient to. It's good to know how to calculate that. And I was like, whoa, wait a second. No, that's not what it is. This is just the number you're using to calculate the protein requirement. But the fact that it says ideal doesn't mean that that's the target weight that I'm trying to get my patient to. Okay. Oops. Back on here. So there's the answer. So now Mrs. X wants to know, what diet should I do? Should I do keto? Should I do intermittent fasting? Should I do low fat? Should I do a commercial weight loss program? So here's some information. This is from New England Journal of Medicine, 2009. So reduced calorie diets will give you weight loss. That's regardless of what macronutrients are emphasized. So you just need a caloric deficit in order to see weight loss. Doesn't matter how much protein, carb, fat. So low fat doesn't matter. Keto, technically, is high protein, low carb, doesn't have to be that, right? So it's important to know that. I'll talk a little bit more about that in a moment. The next one is the big rage these days is intermittent fasting. So this study showed that you're going to get similar weight loss, maintenance, cardiovascular risk factors after 1 year, whether you intermittently fast or you have continuous calorie restriction. So again, this speaks to you just need a calorie restriction, right? However, you'll find with intermittent restriction that there may be more hunger. And that's really important. I mean, to some, you might think, okay, no big deal, but hunger is very strong and there's a reason for it. And, you can't just kind of shuffle it off and say, well, that's not a big deal. I'll deal with it. Of course, there are always certain patients where this will work really well for them. And so I'm not saying that you couldn't have someone do well with this, but I would say most people cannot maintain. And that brings me to this slide. So 2 simple questions to determine if you're going to be successful long-term. Is it safe? Number 1, right? Because if it's not safe, then you're not continuing with it. And is it sustainable? Number 2. And that is really where a lot of things don't hold up. A lot of diets don't hold up. So in my experience, patients that do strict keto, which is 20 to 50 grams of carb per day, they cannot sustain that. They may be able to sustain it for a period of time, but there just comes a point where it's not realistic, or their life circumstances change where they can't pay that much attention and be that strict with their intake. And then inevitably they're off of it. You'll notice that, you know, did I use the word diet on this slide? I don't know. Did I? Oh, I did. I tend not to use the word diet. I really prefer using the word nutrition, because diet is for now. Nutrition is forever, right? And so you're really looking for changes that are going to be more or less forever. Whatever you do to lose the weight, you need to continue to keep it off. And this is really what I often will counsel patients. You know, if you're doing something really extreme, and sure, you'll lose weight with it, but when you can't do it anymore because you can't sustain it, that weight's going to come back. One of the examples I would use is like young females and males who exercise a ton to get weight off. So they're maybe like in the gym or active like an hour to 2 hours a day. That's fantastic. And as long as they can continue doing that, that's great. But inevitably what happens is maybe they start a new relationship or something happens in their life and they're not able to commit that time to that activity. And then the weight starts creeping back, right? Because again, like Dr. Logan talked about, the set point, it just wants to go there. So now meal replacements. So go ahead and read through this question. I'll launch the poll while you're doing that. Okay, so the poll is up. If you're not sure, oh, Dr. Logan taught you all well so far.
It's 100%.
I mean, only 20 people have answered. Oh, people are catching on. Okay, I'm gonna end the poll there.
No.
Oh, now we got some other respondents.
Let's go.
Okay, let's end the poll there. And I'll share. So most of you listen to Dr. Logan's advice. Usually if there's an option for all of the above, it usually is that. But the other answers that were given were not wrong, because it is all of the above. So those aren't wrong. So let me stop the share and just go back. So all of the above. So meal replacements. So these are the meal replacements that we would use in our clinic. The top 3 we would use for partial meal replacement. The only product that is approved for complete meal replacement in Canada is the bottom product, which is Optifast. So complete meal replacement means that the patient is only consuming this and this only. So there's no supplementation with food. And so just for nutrient completeness, Optifast has everything. The others you would use for partial. So that would mean like maybe you're replacing 1 meal or 2 meals of the day with the meal replacement. And then the 3rd meal, they're actually eating real food and getting nutrient that way. So we usually recommend the higher protein versions because you can get like Boost regular and then Boost high protein. Same with Ensure and Glucerna. So just knowing that they require a higher protein intake. The other thing I would say, which I hadn't mentioned earlier, is I usually recommend to patients that they spread their protein intake equally throughout the day. Again, remember, it's a hunger regulator. You know, most people's pattern is that they have very little with breakfast, if anything, maybe some with lunch, and then a big load with dinner. And that's not going to help you with hunger regulation when that's the pattern. So here's Mrs. X's pattern. And again, I would say this is like pretty typical of patients that we would see. So she doesn't have breakfast. She's not hungry. A lot of patients will say, I am not hungry in the morning. She's not hungry. She's too busy. She needs to get out the door with herself and her kids. Her lunch, she either eats out with her coworkers or she has pop at her desk. Her dinner is large portions of a prepackaged meal, or she orders in twice a week. And snacking. She has goodies that are at work, and everybody knows there's always stuff lying around the office. And then in the evening while she's watching TV, she'll have chips or candy or popcorn or something. So in her meal pattern, there are actually a few places where you could use a meal replacement. For breakfast, the meal replacement would be better than nothing, right? Right now she's getting nothing, so she can down it really quickly and be out the door. For lunch, eating out is notoriously calorie heavy, especially if you're not paying attention to portion sizes. So, you know, it could replace that meal. Of course, that's not as fun as going out with your coworkers, but it could replace it to reduce the calories in that meal, or to improve the nutrition, because the pop is really just sugar and there's no actual nutritional value to the pop. So it would improve her nutrition there. The dinner, large portions of a prepackaged meal, which is often like convenience foods. Same thing there, large portions, you're going to have higher caloric intake. Eating out or ordering in, sorry, is the same as eating out. It's, you know, high calorie if you're not watching your portion sizes. So here she could use it to reduce the overall caloric intake for dinner. So I'm not suggesting that Mrs. X needs to be on complete meal replacement. Ideally, maybe she would use it for one meal, and then the other 2 meals she would plan a little differently with maybe some education, knowledge, and eat real food in those meals. Finally, the snacking, the goodies at work. So this is quite common. Really, if she had a breakfast with protein, she probably wouldn't be as tempted to have those goodies at work. The chips, candy, popcorn in the evening, this is actually not something that I would use meal replacement. This is emotional eating. So this is a different trigger for eating. It's mindless eating, boredom eating, habitual eating. So that is addressed differently. Now we come to activity. So when you tell them you need to move more, well, how much more do you need to move? So read the question. I'll throw up the poll. If you were paying attention in Dr. Logan's presentation, hopefully you'll know what the answer is here. So what is the recommended minimum number of minutes of activity per week as per the Canadian Physical Activity Guidelines?
I got them. Hold on.
So I'm going to close this poll in about 5 seconds. Okay, ending the poll. Sorry if anyone didn't get a chance to respond. And here are the results. Oh, it looks like most of you were paying attention during Dr. Logan's talk there. So it is actually 150 minutes. Let me just get back into my, it is actually 150 minutes. So these are the actual Canadian Physical Activity Guidelines. I'm not going to go through them. You will get these in the slides. What I do want to bring your attention to is the right side of the screen here, where it says being active for at least 150 minutes per week can help reduce the risk of, and it gives you a list. Bottom of that list, it does say overweight and obesity. And then under that, it says, and can lead to improved fitness, strength, mental health. Nowhere in there does it say weight loss, and that's on purpose. So here's the next poll. Read it through. I will pull it up here and launch it. So how many minutes of activity are required per week for weight maintenance? Good, people are answering, good. Answers are still coming in. I'll give you another 5 seconds here. Okay, I'm closing the poll, and here are the results. So 50% thought it was 200, and then a smaller percentage thought it was 150, and then a few thought it was a little less or a little more. Okay, so stop the share. Let me just get back into my presentation. So the actual answer is 200. You actually need more than the recommended to maintain your weight. And some of that I think really has to do with muscle maintenance. Remember, again, your lean muscle mass is really what drives your metabolism. So if you want to keep it up, especially as you age, then you need this activity. So recommended levels of PA may produce weight loss. However, if you are relying on activity alone, so you're not making any nutritional changes, you're looking at 60 minutes a day. And, you know, for most patients, I would say they don't have or want to spend that amount of time. 60 minutes a day in a week, like we talked about, 150 is the recommended in a week, 200 to maintain. 60 minutes a day is 420 minutes per week. Okay, so that's more than most people can manage. This table is very telling. Okay, I'm just going to bring your attention to certain parts of the table. So the first thing to see is the flat line on top at 0. So 0 weight loss. That is advice alone. So that's you telling a patient, eat less, move more. Really doesn't get you anywhere. The second line below it, which is the dark black line that is shorter, this is your exercise alone line. So you can see you get a bit of a loss. I think it kind of comes to like just over 2 kilo-ish loss, but you also see there's that rebound back upwards. And so ultimately you're not really that much further ahead than you were. The third line that you see below it is sort of a navy bluish color. That is your diet alone, or as I would say, nutritional change alone. So nutritional change definitely gives you more. And this is the reason why when I start with patients, I will always emphasize the nutritional change first, because I know that activity can come later. And generally speaking, when people start to lose, they feel better and they want to be more active. They just don't maybe have as much energy as they would like for it. So as they lose, they can feel better and get more active. So that's my reasoning. And then the last one I will bring your attention to is the bright red line. So that bright red line is the diet plus exercise. Neither of those terms do I like. So nutrition plus activity line. And that gives you the greatest difference. Again, you will see that there is a bit of regain, and I think probably Dr. Chapelski will be talking about that in her talk coming out. So how many minutes do you need to walk at 3.5 miles per hour to burn off 290 calories? So I'm going to get this poll up. I can find the mouse. There we go. Oh. Here it is. Launch. So if you're not sure, just give your best guess. I'll give you another 5 seconds to answer here. Good, I think it slowed down, so I'm going to end the poll and share the results. So there was sort of a tie between 55 and 75, and then some people thought maybe 35. So let's stop sharing. So the answer is actually 55 minutes. I actually went on the treadmill the other day just to see what is 3.5 miles per hour. That is a pretty brisk clip. So for me, I'm like 5'4", and my legs are a little short for my height. But this is about like 2 steps per second is what that speed would be, just to give you an idea. So this shows you kind of what you could expect to need to do activity-wise to burn off this number of calories, okay? So I've done a little bit of math. You don't have to do this. So the patient that comes into you and has gained 10 pounds in the year over 12 months, what has their excess been per day on average over that year? And so if you do all the math, 3,500 calories per pound over 12 months or 365 days, what you actually come to is that their excess per day over their BMR was 95 calories. Okay, it was 95 calories every day for the year, and they got a 10-pound gain. So you don't usually see patients, like maybe patients will gain 3 pounds or 5 pounds or whatever, but you can certainly see over the years, over 10 years, over 15 years, 20 years, how this can really add up. So, you know, you have to do like 26 minutes of walking to, you know, burn off that 138 calorie sugary soft drink. That 26 minutes is kind of, you know, your 150 minutes per week. And most people wouldn't be aware of that. So why bother even recommending activity, you know, if it's so ineffective? So definitely activity can improve health without having any weight loss. I'm going to bring your attention to the chart on the right side of the screen. So this is 3 months of regular activity, 40 to 60 minutes a day. And you can see that the weight change is really minimal. So 0.1 kilos is equivalent to like 0.22 of a pound. So it's like just over a fifth of a pound over 3 months. Like how many patients would be happy with that? but you get a waist circumference change of 3.1 centimeters. And then you see really where that negligible change comes from. 1.6 kilos lost in fat, but then they have a 1.5 gain in lean muscle mass, right? And that's a good thing, but they're not going to see that. You also see that their insulin sensitivity is considerably improved, right? So there are definitely benefits, right? It's not, you don't want to just say, well, you don't have to do it, it's not important. So what would the activity prescription look like for Mrs. X? So I'm going to put up the poll, go ahead and read through the answers there while I do that. So the poll is up. Good. Oh, I can see this, but you can't. Nobody seems to like B and C. Okay, I'm going to close the poll here and we'll share the results. So yes, the answer is actually D. Let me just stop the sharing and get back into my, you know, the physical activity recommendation is 150 minutes per week, but really when you're talking with patients, you know, you may not get very far, and this will come up in the behavioral therapy portion of this talk. You may not get very far if you just tell them this is what you need to do. So ideally it's something she enjoys. You're always going to have that patient that says they don't enjoy any activity, in which case I would just say, well, you know, most everyone can walk. So if you're able to walk, then that's enough. You don't need to run. You don't need to do anything overly strenuous that you're sweating buckets. Doing safely is very important. I find a lot of patients, they'll get really motivated and they will go gangbusters and they will hurt themselves. And once they have that injury, they really set themselves back immensely. So they should start slow, build it up slowly over time. So now we come to behavior therapy. Motivational interviewing. So you may have seen this in other contexts, trying to create change. So this is sort of the definition. Motivational interviewing to me is like, it's guided self-empowerment, okay? So you're trying to assist the patient to come to the solutions on their own. And if you think of it as like, I kind of think of it as you're walking beside the patient, you're letting them make the decisions of what direction they're going and how quickly they're going in that direction, versus standing behind them and pushing them, or standing in front of them and pulling them in a particular direction of your choice. So here is our polling question. So there's a lot of writing there. Go ahead and read that and see what you think. And I will launch the poll and answer whatever your gut tells you. Good. I will give you another 5 seconds here and then I will close the poll. Okay, perfect. I'm going to close the poll here. So if you didn't get to answer, I apologize, and share the results. Yeah, so I think you guys caught on there, hopefully. Let's stop the sharing. Sorry, I'll just get back into there we go. So yes, the answer is B. You know, what do you think that you can do to stay active and still have adequate pain control? So the basic skills with motivational interviewing are expressing empathy. You know, you're not judging them. You understand, you're hearing what they're saying, develop the discrepancy, kind of show them, where do you want to go? What is the goal? Where is the mark? Roll with resistance. I find this is quite important because oftentimes patients will say, I can't do that. And if you respond with, well, yes, you can, that doesn't tend to get you very far. So agreeing and saying, well, maybe you really can't do that. What can you do? And kind of throwing that ball into their court. And then, supporting self-efficacy, which is kind of, throwing the ball into the court, saying, what do you think you can do? What resources do you have at your disposal that you'll be able to do something? So this next part, I'm just going to pause here if I can. Oh, how come I can't pause it? Can you pause it?
Many times, patients set their goal as the number on the scale.
Sorry, I'll just pause it to let you know. So this is Dr. Dana Lee Bagley. She is a clinical health psychologist out in the East Coast. And so these next two videos are going to play back to back, and they are talking about setting behavioral goals with patients. She says it much better than I do. So, and they're short videos. So let's go ahead and listen to them.
But really, it's the change in behavior that is the true goal. As clinicians, we can help guide patients set a behavioral goal that makes sense for them and that they can continue. Ultimately, these changes in behavior will lead to a more sustainable weight. It's also physicians who set weight as the goal. Focus on setting a health behavior rather than using weight as an outcome. Behavior is something that is measurable, observable, and meaningful to the patient, and make sure they are 90% sure they can achieve it. Setting behavior as the goal has a better likelihood of resulting in long-term change, which is what we need to effectively manage this chronic disease. Set achievable goals and build your way to the ultimate goal, keeping in mind that success builds success.
And the next video.
It's important to be collaborative rather than prescriptive in your approach to goal setting with your patients. It's a good idea to start with a question, such as, would it be okay to talk about setting some goals for activity? An example of a prescriptive approach would be to ask a patient, would you be able to increase your walking activity to 3 times a week for about an hour each time? Or build a 30-minute walk into your daily routine? A more collaborative approach includes the patient in the planning. For example, you could say something like, it's great that you're walking twice a week. Are you interested in increasing your walking activity? How would you like to increase it? By the number of days per week? Or by the intensity or duration of existing walks? What would work best in your life? And are you 90% sure that you can achieve that? If the patient says no, you can work with them to set an achievable goal.
Okay. So the next is cognitive behavioral therapy. So I'm sure many of you might be familiar with the use of cognitive behavioral therapy when it comes to depression or anxiety. This is the definition. It's maybe better seen in this pictorial. So it's the idea that thoughts lead to feelings, lead to behavior that then lead back to thoughts. And definitely if you have negative thoughts or distorted thoughts, then you kind of get into this vicious cycle. So how this applies specifically to obesity would be the thought distortion might be something like all or nothing, black or white thinking. And so in a patient that's dealing with obesity, maybe they have had one poor choice or they had one bad food choice meal, like they went to McDonald's for breakfast. So for them, with that thought distortion, the rest of the day is a wash. I'll start again, the diet starts again tomorrow. And so then that leads to feelings, and those feelings are frustration and guilt because they knew they did something that they didn't want to do that doesn't help them with their goal. But there's also probably some relief involved there because now there's sort of implicit permission to do whatever they want for the rest of the day because they'll start fresh tomorrow, right? So then that leads to behaviors, and those behaviors would be like an increase in emotional eating, an increase in portions, and potentially even binge eating because there's sort of a time limit. It's like, I need to do whatever I can now because I'm going to have to restrict again come tomorrow, right? And then the piece that's not in here that our psychologists will add in for patients is the consequences. So because the consequences are really what tend to lead to the thoughts again, right? So the consequences would be that their weight goes up, they're angry, frustrated, guilty, their self-esteem decreases, their body image decreases, their sense of self-body image decreases, and they are further from their weight goal. And so then that leads to the negative thoughts again. And those negative thoughts would be, I should have had better control. Why can't I do anything properly? Why am I such a failure? These types of things. And that perpetuates the cycle around and around. So the idea here is to stop the cycle somewhere, bring the patient's awareness to those thoughts, feelings, behavior, and be able to control them a bit better and intercept them essentially to stop the vicious cycle from going on. So yeah, you had a poor meal choice. That doesn't mean that you can't make good choices for the rest of the day, right? If you have a day that doesn't go well, that doesn't mean you're a bad person, right? So it's sort of that idea. Acceptance and commitment therapy. So this is used more in the context of the motivational interviewing. I'm not going to spend a lot of time here. But this again pictorially sort of shows you what is involved. So our psychologists would use sort of the values part and the acceptance part, maybe not so much of the other things. So values, discovering what is actually important to you. And then the acceptance is, accepting things that you can't change. So in the setting of a person struggling with obesity, that would be like, I can't change my genetics. I can't change my physiology. I can't change the fact that I have an abuse history or trauma history. So, that's important. And I also can't change other people. So what other people say or do, I cannot change that. And the idea is to help them bring the locus of control more internally, so that they're not looking at external factors to improve in order for them, that they themselves to make change. So you're not looking for everything to be dependent upon someone else doing something, or even pharmacotherapy and bariatric surgery doing everything in terms of their behavioral change. So that's what this is. So finally, self-monitoring and assessment tools. So self-monitoring is really important because it brings awareness and it brings accountability. Research shows that a person that keeps a food journal with no intention of restriction, so they're not trying to keep within a certain caloric limit, they're just documenting everything that they eat, will actually have weight loss over 6 months, okay? I sometimes with patients that are particularly number oriented, I will use the analogy of a budget. So your BMR is like your fixed expenses. That's what you need. And then just like with money, if you don't actually know how much you need, how much you're making, and how much you're spending, the likelihood is that you will end up in debt, because it is much easier to spend money than it is to save money. So same thing with your calories. If you don't know how many calories you need, you don't know how many calories you're taking in and how many you're burning, then the likelihood over time is that you're going to gain weight, right? Because it's much easier to take in calories, as we saw with the table with how much it takes to burn it off, than it is to burn it off. Okay. So food journal apps that are useful. MyFitnessPal is the one that our clinic recommends, although there are a number out there. I don't know that it really matters which one you use, and there's absolutely nothing wrong with pen and paper. And oftentimes we will ask patients also to journal their emotions with their food so that they can start to see what the connections there are. So this is MyFitnessPal. I just put these in, but I'm not going to go through them in detail. Basically, there's 4 steps to signing up. MyFitnessPal is free. The base is free, and it does calculate for you like what your calorie requirement is and stuff. The patient can go in and alter those themselves. You can manually change what the protein target is and that kind of thing. But this is what we recommend in our clinic. And then fitness apps, Fitbit, Garmin, MyFitness, or MyFitness. So again, you don't actually need these. A basic pedometer that counts steps is fine. And even if they don't have that, there is nothing wrong with pen and paper. So if they write down that they went for a walk for 20 minutes that day or 10 minutes that day, whatever, and that's how they're recording, that is adequate. So how often, I'm going to throw up this while you read it. So how often should a person weigh themselves for monitoring purposes? Good. I'm going to give you another 5 seconds here. Perfect. I'm going to end the poll here. And these are the results. So most people picked weekly. There were a few that said daily, a few that said monthly, and a few that said never. So I'm going to stop the share. And so the answer that I would say is weekly. Okay. So there's some tips. These don't obviously have a resource attached to them. These are just my personal kind of tips. So when you weigh, I really wouldn't recommend more than once a week. Again, analogy for patients is your weight is sort of like the stock market. If you look at it all the time, then you see all the ups and downs, and it can be very misleading and aggravating and anxiety provoking. What you really want to see is what the trend is over time. And so you're more likely to see that if you're just doing once a week. For women in particular, I often will tell them just be aware of fluid changes with your menstrual cycle, that may result in what looks like a weight plateau, particularly the week going into the cycle, and that if you just wait it out, you're consistent with what you're doing, that you will see a larger kind of drop afterwards. And so it's to prevent the panic that happens when people don't see a change and they think, I'm putting all this effort in, it's not working. It is working. There are just other factors involved you need to be aware of. And that same thing with just general weight plateaus for anyone. You know, the weight is going to plateau somewhere, even with pharmacotherapy. Sometimes I jokingly tell patients, you know, you're not just going to lose weight until you disappear into thin air, right? It has to stop somewhere. And when it stops, that doesn't mean that the medication isn't working. And it doesn't mean that you need to change something drastically, because oftentimes that is where patients will panic. They'll think, I need to do something more extreme. I need to get this number going down again. And usually the changes they make are not sustainable. So remember, long-term, we need things that are sustainable. And they don't realize that if they just stuck with what they were doing, which is working, is working, that they need to look at other indicators of health. So they might see that waist circumference continues to go down, body composition continues to improve, their quality of life, their energy levels may continue to improve, but the number on the scale will stubbornly not be moving. So finally, here are some resources. So these are Alberta-based, however, they are available to anyone and everyone. So I've checked these links just the other week. They do work. These are online modules, and then these are community programs. Now, the community programs, I don't know if you need to be within province for these, but they are still being offered over Zoom now, no longer in person. But they are, I've had good feedback that they are quite effective, quite helpful, and quite interactive. And then finally, this is the reference cheat sheet. So the bottom part, I really have not talked about that. Really, the part that I want you to look at is the top chart there. That's it for me.
Okay. All right, you guys. So Dr. Kwan said she would catch us up.
Did I know?
Oh, no. Okay, so I'm going to address the questions really, really quickly here. There's a lot of chatter between PCNs in and around this area, like in Alberta, and I'm going to tell you, PCNs are going to change the landscape of how we do chronic weight management. That is where a lot of the work needs to be done, and that is where this chronic disease is we're going to kill it. We're going to crush it in the community with PCNs. So a lot of work's being done there. So there's some quick questions. Multivitamin. So I actually looked up stuff like dietary guidelines and stuff while Dr. Kwan was talking. I think the thing is we want to make sure patients get good nutrition and meet all of their vitamin mineral requirements. So when you're eating less, the concern is, are you getting all your vitamins and minerals? You can check them. If someone's on a lower diet, you can check iron and B12 and calcium and vitamin D. But one of the easier things is if they're on a lower calorie diet, to just take a multivitamin. I think Canadian guidelines support taking an age-appropriate multivitamin. And then there was questions about, what happens during periods of weight loss, like metabolism. Dr. Chapelski will speak to that. So there's lots of stuff about that. And then talking about using Contrave for hunger and cravings in intermittent fasting. Remember, we can use any of our weight loss medications with whatever way of eating a patient. So I just call it a way of eating. I know we use the word diet loosely. So medications augment our patients' weight loss efforts and they make them more manageable. They sustain their behavior changes. So that's that question. And then meal replacements. I liked this one. So there are certain meal replacements that are approved by dietitians. And when they're approved by dietitians, that means they've been scrutinized, they meet all requirements. Can you make your own protein shake instead? Yeah, instead of skipping breakfast, if you can make a protein shake, I think that's great. People just like the convenience of pre-made protein meal replacements. And so there's just a couple that are recommended by the dietitians because they're assessed. And then there's some questions about, again, metabolism, wait. Fun to read this. I feel like I'm intermittent fasting right now. I had breakfast at 6 a.m. So I'm technically intermittent fasting right now. And then I think that was about it. Sorry about running late, you guys. We are going to not be able to catch up, so please grab something to eat. And I'm going to move. Here's the evaluations. Just go to the chat box, hit the link. I'm going to keep moving along here. So I'm the next speaker in line, but lucky you guys, I brought along with me Dr. Alina Litviak. So she was referred to previously in Dr. Karen Lee's presentation as well. She helped Dr. Lee. So she's currently pursuing her obesity medicine fellowship with us here. So I'm going to introduce her. Dr. Litviak is joining us. So she completed her medical school in Ukraine and actually obtained her PhD in gastroenterology. She actually worked with Dr. Fedor at the University of Alberta. In 2009, she was awarded the Fulbright Scholarship and Hubert Humphrey Fellowship by the United States Department of State. She completed her postdoctoral fellowship here at the University of Alberta. Dr. Litviak has always been interested in obesity medicine and excess weight management and prevention at both the population level and individual level. She's author and co-author of 89 peer-reviewed journals, publications. She's a senior resident presently with the Public Health and Preventative Medicine program at the University of Alberta. And she's currently pursuing the Obesity Medicine Fellowship with us through, I'm her supervisor and Dr. Karen Lee. So welcome, Alina. So we will be reviewing the tools and templates for obesity practice. I do have a few disclosures to comment on myself. I am a member of Novo Nordisk, Takeda Pharma's, Bosch Health, and Obesity Canada Speakers Bureau, so I do receive speaker fees. I also receive consulting fees primarily for the development of CME accredited educational materials. I also attend advisory board meetings. I chair advisory board meetings, and I also provide education to healthcare providers here at the Bariatric program, which is probably my favorite thing to do, working with people here. They come here, they come virtually now. We chat a lot, we work through my list, we stay late, and it's really fun. And that's under the umbrella of a mentorship program. Dr. Litviak does not have any disclosures to comment on, and she does not have any conflicts of interest yet. And then finally here, as mentioned previously, the content of this program was completely developed independently, including this slide deck. Mitigating bias, content was developed on a needs assessment poll. The presentations are for educational purpose. They're balanced, they're unbiased. Evidence is, all data is evidence-based and in alignment with clinical practice guidelines. All right, so here are our learning objectives. Okay, over the next 40 minutes or so, we're hoping to simplify obesity practice in your office. So we want you guys, we're going to share with you tools and templates that make it faster, more straightforward. We'll review the standard calculations super quick because Dr. Kwan did a great job of that. And then we'll share the templates we use in our clinical practice here because the Bariatric program is streamlined for clinic efficiency, and we do have a lot of different types of clinicians here. So Dr. Litviak will take it from here.
Thank you very much, Dr. Modi. And good morning, everyone. Welcome, and thank you so much for joining us today. So we would like to start by sharing the health information questionnaire that all of our patients complete upon entering our program. It's a very comprehensive questionnaire because the main difference in assessing a patient for chronic weight management is that the history should include detailed weight history, nutrition history, and assessment on physical activity. With regards to weight history, it's very important to find out when your patient first became concerned about their weight, what was their peak weight and when it was. We also need to identify triggers for weight gain and weight regain sometimes, and also we need to discuss expectations. With regards to nutrition history, you can see this is very detailed assessment of eating behavior and food choices. This has been refined by our registered dietitians in our program and therefore is very, very concise. So patients may identify with various issues, including dysregulated meal pattern, excessive grazing and snacking, poor food choices, and so forth. We also review previous weight loss attempts and whether they were successful or unsuccessful. It's also very important to assess functional status and physical activity levels. People may have many comorbidities, and the most common probably is osteoarthritis. Therefore, it's very difficult for them sometimes to meet those recommended levels of physical activity. So those activity recommendations should be absolutely individualized, and goals for those physical activities, they need to be set in collaboration with patients. Finally, we also assess interest in different treatment options, such as our anti-obesity medications, lifestyle changes, and also bariatric surgery, of course. The remainder of questionnaire is a standardized health questionnaire, which includes social history, habits, medical profile, family history, previous surgeries, medications, allergies, and potential associations with other specialists in the community. Next slide, please. So moving on to tools for practice, we use a number of validated screening tools at our initial assessment. You are familiar with most of them, and first of those is GOT7 screen for generalized anxiety disorder. Next, we use PHQ-9 to screen for depressive symptoms and major depressive disorder, attention deficit hyperactivity disorder, self-report scale, BET7 screening tool to assess for potential binge eating disorder, and finally the Epworth Sleepiness Scale. Next slide, please. Okay, so before we review the screening tools we use in our day-to-day practice, we would like to briefly discuss the concepts of sensitivity and specificity. And then you will see practical application of those when we are going to review our screening tools. So sensitivity is a percentage of individuals with a disease who are correctly identified by a given test. Specificity, on the other hand, is the percentage of individuals without a disease who are correctly excluded by the test. As you will see later, the validated tools we use in our practice generally have high sensitivity and high specificity, and therefore are very reliable tools. Next slide, please. So here is our first quiz question. So how do we call the ability of the test to correctly identify people with a disease?
All right, you guys, so I've launched the polling question. You guys should all see it. I'm going to actually ask you guys, this is a set of 4 questions, so I'm going to walk you through this. So answer each question. How do we call the ability of the test to correctly identify patients with the disease? Is that sensitivity or specificity? Go ahead, submit your answers. Did you submit? It's not showing.
No, it wouldn't.
Oh, there it goes.
We have
You have to submit, you have to go all the way to the bottom.
submit all of the
Question
answers.
2, 3, and 4.
Answer all the questions.
Submit them all, Sabrina. So keep scrolling down and go through all the questions. Sorry about the change up, Alina.
It's okay, no worries. Yeah, it will take some time.
Mm-hmm. There's still some answers coming in. All right, I think I'm going to end the polling. There's just still some movement. Okay, you guys, 5 seconds, and I'm going to end the polling. All right, I'm going to end the polling. Okay, so Bibi, what are you doing? I'm going to share the results. Bibi's right beside me. So here are the results. How do we call the ability of the test to correctly identify with the disease? That's sensitivity. And you can see here, 37 of you guys picked sensitivity, so the majority. And then I'm just going to stop sharing, and we can go to the next slide. The correct answer here was sensitivity. All right, Alina, there you go.
Yeah, excellent. So now is the second question, and I believe everyone already provided an answer for that one. So how do we call the ability of the test to correctly identify those people who do not have the disease, rule out the disease?
Yeah, and here it was the vast majority thought it was specificity.
Good job.
Yeah,
Okay,
and the
next slide.
answer is specificity. Yeah.
Yeah. Okay, so now we are moving to the GAT7 screening tool, which helps us to assess patients for potential generalized anxiety disorder. Here we are assessing symptoms going retrospectively for the last 2 weeks, and we are generally asking about feeling of anxiety, excessive worry, difficulty controlling thoughts and relaxing, feeling restless and irritable, ruminating and catastrophizing thoughts. Also, as you can see on the bottom, very important point, here we are also assessing for potential impairment our patients can experience in their home, work, and social lives. Next slide, please. This is how we score the GAT7 screen. Typically, if patients have a score of 10 or greater, it warrants further assessment. As you can see here, the GAT7 tool is a highly validated tool with excellent sensitivity, which is close to 90%, and very high specificity of 80. Next slide, please. Here is our PHQ-9 screening tool, where we assess our patients for presence of any depressive symptoms and presence of major depressive disorder. Once again, we assess for symptoms going back for the last 2 weeks. And here we are probing for anhedonia, low mood, difficulty with sleep, rating for our patients' energy levels, low appetite or overeating, self-esteem, concentration, psychomotor retardation, and of course, we are assessing for safety for suicidal ideation. Most of us are familiar with this screening tool, which is used pretty widely in clinical practice. And also, as you can see on the bottom, the very important point, here we are also, similar to GAT7, assessing for potential impairment in our patients' home, work, and social life. Next slide, please. So similar to GAT7, score of over 10 for PHQ-9 warrants further assessment. And again, as you can see, the sensitivity and specificity for this test is actually was shown in different studies varying a lot, but it's very reliable. It's over 80%. So again, it's a validated tool, which is very useful in our clinical practice. Next slide, please. So moving on to ADHD self-report scale, this is specifically part A, the screening portion. Here we are questioning task completion, organizational skills, procrastination, restlessness, and impulse control. And we are looking into these shaded boxes to the right. Okay, next slide, please. So on this part A of the ADHD screen, a score of at least 4 warrants further assessment. As you can see here, specificity is remarkable And therefore, this specific part A helps us to accurately exclude those individuals who do not have ADHD. However, as you can see, sensitivity is a little bit lower. And therefore, for this reason, there is part B, which complements part A, and we use part B if we need more detailed follow-up assessment. Okay, next slide. And yeah, now we are moving to BED7 screening tool, which is basically a snapshot from the DSM criteria for binge eating disorder. This is a little bit different from GAD7 and PHQ-9 because here we are probing eating behaviors over 3 months period of time. Here we are assessing for overconsumption, feeling of distress, lack of control over food consumption and food choices, going beyond satiety, feeling ashamed and guilty afterwards, and the most important, frequency of those episodes, which helps us to distinguish whatever our patients have just binge eating episodes, which a lot of people may have from time to time, or this is specifically binge eating disorder. Next slide, please. So in this screen, if the patient answers no to question 1, there is no need to move forward with assessment. If their answer to question 1 is yes, then we are moving to question 2. If our patient answers yes for question 1 and 2, and also ticks one of those shaded boxes from questions 3 to 7, again, further assessment is warranted. The decision to diagnose our patients with binge eating disorder is purely based on DSM criteria. As you can see here, the sensitivity is perfect. So if patients have binge eating disorder, it helps us, all the screening tool helps us to correctly identify those. But specificity is significantly lower, and therefore some of our patients would need further assessment. Next slide, please. So overall, talking about screening for mental health disorders and different disruptions in eating behavior, I cannot emphasize enough how important it is to ensure that mental health disorders in our patients are comprehensively assessed and properly managed. Because such conditions are commonly present in people living with obesity, and therefore chronic weight management can be far more challenging if management of those disorders is not optimized. Next slide, please. And here is our final screening tool. Again, you may be familiar with Epworth Sleeping Scale, and this is specifically a self-reported portion of it. So here we are assessing patients for potential presence of obstructive sleep apnea, which is commonly associated with carrying excess weight, as you all know. And on the next slide, you will see how do we score it. So the score of at least 10 for self-reported portion suggests the possibility of sleep apnea. And if we suspect this, we can then proceed with objective assessment, which is a separate part. And here we will need to measure neck circumference. We need to assess for presence of snoring or gasping during the sleep. And also we are assessing for presence of hypertension. Then all these numbers are summed and it gives us the final score. But even for this self-reported portion, as you can see, sensitivity is remarkable and specificity is basically perfect. So even if we have score of 10 and greater in our patients, it can actually tell us that there are very high chances that our patient actually has obstructive sleep apnea. Again, all these validated tools have high sensitivity, high specificity, are very reliable, and we use it in our day-to-day practice all the time. Next slide, please. And we also would like to share with you an example of a consult note that is used by one of our clinicians at the bariatric clinic here. So the point here is, again, the uniqueness of a chronic weight management assessment, which includes detailed weight history, nutrition history, and physical activity assessments. As you can see here, we are also capturing results of those screening tools we just discussed for mental health, eating disorders, and obstructive sleep apnea. And of course, we screen for other well-known comorbidities associated with carrying excess weight. Overall, in our clinic, the main goal is its efficiency and streamlining of the whole assessment process in order for more of our patients to have access to our care.
Okay, thank you, Dr. Litviak.
Thank
So
you.
I'm going to get started and walk us through a case presentation. So meet patient Nadine. Nadine is a 44-year-old single mom. She gained weight in pregnancy. She does have a history of yo-yo dieting and currently weighs 229 pounds or 104 kilograms with a body mass index of 33.5. Thus, she does have class 1 obesity. Her hypertension is well managed by her family doctor, and she does have PCOS. She is very concerned about her weight, and she is interested in medical weight loss. I think one of the most important things to do in primary care or in chronic weight management is we need to identify patients. Patients need to self-identify themselves, or we know our patients to start the conversation about patients who are ready to engage in behavior change. So assessing Nadine's behaviors, okay, and barriers. She works at a government office job. This is a sedentary job, and she tends to eat out for lunch. Her mom comes over after school and takes care of her son, so she does aftercare and preps supper. Nadine tends to overeat at supper. She struggles with hunger. There are calorie-dense food choices around the house. Her evenings are alone, so mom leaves after supper, and it's just her and her son, and she's in charge of all of his activities, homework, housework, a lot. So thus she doesn't have time for meal preparation, and she sure as heck can't carve out time for physical activity for herself. Lots of stressors. She's a single parent, tight budget, work stress. And Nadine does identify with the link between her emotions, how she feels, and her eating behaviors. So again, 1, identify patients who are ready to engage in behavior change. Step 1. Step 2, there's a lot going on here, right? But we need to know as clinicians, we don't need to overwhelm ourselves. We don't need to shift the burden of the disease from the patient to our shoulders. We need to make sure that we don't overwhelm ourselves and overwhelm our patients. So we need to actually select a couple of goals and work on those between visits and see our patients frequently. So here's the quiz question you guys already answered. So I'm going to go back and share the results. So that was question 3, I believe, which of the following behaviors are associated with long-term weight management? And most of you guys thought all of the above. So eating several smaller meals, eating breakfast, joining a weight loss program, watching less television. I'm going to stop sharing. So the actual answer is B and D. Eating breakfast is associated with long-term weight management and, of course, watching less television. Okay. What lifestyle changes might you focus on first? Pardon me? This is in the same pool, Libby. What lifestyle changes might you focus on first with Nadine? Reducing her caloric intake. Maybe you will recommend a specific diet or way of eating. Talk about activity, okay? And then you can do none of the above or whichever one Nadine selects. So I'm going to share the results. Oh, where's that question? Okay, I'm going to close the poll. Hold on one second, you guys. Did they answer this question? Stop sharing. Okay. There we go. Now I'm launching this question. Now we're back to our normal system. Now you guys can, there we go. So now we're going back to answering questions the old way? Okay. There's one that's on that one, but I have it on my board. Okay. But how will I share that result? Okay, a couple more seconds. I'm going to end the polling, you guys, to keep us going, and I'm going to share the results. All right, so you can see, or most of you thought whichever one Nadine selects. I'm going to stop sharing, close the poll. So the correct answer here is whichever one Nadine selects. Okay. So here's Nadine's list of things she wants. So again, she wants to eat these are all great goals. She wants to have breakfast every morning, maybe have a snack after work, which will help manage her hunger at supper time. Work on portion sizes, maybe do a cooking class with her mom. Maybe her mom can watch her son while she does the cooking, get trigger foods out of the house. She wants to keep a diary of her food intake, and she wants to make time for activity. Again, patients will have a long list of things they want to do and all the changes they want to make, and they want to do them in the next 24 hours. So again, picking 1 or 2 goals and working on them between visits and seeing your patient on a monthly basis. Doesn't that sound so much more manageable? Of course, for not just you as a clinician, but also for the patient. And you just need to guide them that way. So here is another quiz question. The Obesity Society recommends the following lifestyle measures. I think you guys answered this. What was the answer? What was the polling result? What did they answer? Hurry, hurry. I can't read that now. Move it away from my face.
Most of them say A and C.
A and C. Caloric reduction and self-monitoring. And that is the correct answer. Okay. All right, so remember 2 basic calculations you need to do whenever you're doing chronic weight management. Calculating someone's resting metabolic rate. You know, what calories does my patient burn at rest for like breathing, blood circulation, body cell growth? There's an equation for men and women, and Nadine's resting metabolic rate is 1,759 calories. So if she consumes about 1,800 calories per day, she won't gain, she won't lose, she'll be weight stable. Okay. You can multiply by an activity factor. Don't do that because people overestimate their activity, whether it's the intensity, how many calories they burn, and it's not consistent day to day. So Nadine's nutrition prescription, we want to create a 500 caloric deficit diet. So we subtract 500. And so she's going to now target 12 to 1,400 calories per day. So Nadine needs to target 12 to 1,400 calories per day. But you would never just tell a patient to do that. You would never just tell a patient to do that. That's like saying, eat less, move more, and sending them out the door. So we wouldn't do that. So to refine her nutrition prescription, we need to calculate her protein needs. Okay, so you have to calculate ideal body weight, which is based on a BMI of 24.9. So Nadine's ideal body weight is 77 kilograms. And if you recall, her weight was 104 kilograms. Okay. So there's an upper and lower limit. We target 1.2 to 1.6 grams of protein per kilogram ideal body weight. And remember, this is during the period of active weight loss. Okay. So her upper limit is 123. Her lower limit is 92. Okay. So now we refine her prescription. She's going to target 12 to 1,400 calories per day. And she's going to have to target 100 to 110 grams of protein per day, which is a lot. So this is her nutrition prescription, but again, we wouldn't just say you need to do this, right? Eating less, moving more is not evidence-based. It's not evidence-based. All right, considerations in selecting an appropriate agent for Nadine. This is the most important one, cost and coverage, right? Are they covered? Do they have Sun Life, Manulife, Great West Life? Are they willing to pay out of pocket? Do they want oral? So naltrexone, bupropion, tablet form, or a sub-Q injection once a day versus BID dosing. Review the side effects. Do they struggle with hunger, portion sizes, lack of satiety? Do they struggle with emotional eating, or, you know, there's a link between how they feel and their eating behaviors? Do they have diabetes? Do they have pre-diabetes? Do they have a mental health history? Are they a smoker? And then, of course, the contraindications come into play. Again, you're going to collaborate with your patient, right? So you have a good idea of what she needs to do. You're going to discuss the medications, right? And then together you'll collaborate on goals and what medication she chooses to go on. So what is the rationale for prescribing anti-obesity agents? Okay, is it additional weight loss? Okay, improving cardiometabolic parameters and improving maintenance of weight loss, or all of the above. So I'm going to launch the poll. So this is how this was going to work. Which question am I at now? Here we go. This is how it's going to work. Now we're back to how it's supposed to work. So go in, submit your answers. Easy. Keep going, keep going. Numbers are coming in real quick here, you guys. 5 more seconds. I'm going to stop the poll, share the results. So again, all of you guys thought the answer was all of the above. And that is the correct answer, all of the above, okay? So to keep things streamlined in the clinic, we have these worksheets. And so this is the liraglutide initiation worksheet. There are 4 sections, as you can see. So section 1, 2, and then there's 3, and then there's 4. And we also have naltrexone bupropion worksheet. And again, I'm just going to say section 1 and 4 are the same. Those 2 parts are similar between the 2 meds. And then they diverge in section 2 and 3. So let's just walk through this. And I just picked the liraglutide initiation sheet. We're not biased towards either of these medications. We use them both equally all the time. So liraglutide, we ask our patients. So I'm going to tell you the LPNs room our patients for us, and they go through this with the patient. So they talk about hunger, lack of satiety, right? They talk about cravings. Do patients struggle with head hunger, emotional eating? Are they, able to weigh themselves maybe once a week, maybe maintain a food diary, probing patients, asking them if they have 3 meals. It is important, we don't want to dysregulate patients. So if they're skipping meals all the time and they're really dysregulated, we don't want to make that worse by adding a medication that makes them not hungry all day. So we do want some balance. Then we talk about our recommendations. So we recommend 3 meals a day if they can, so not to skip meals. We also don't want them to graze. We want them to have discrete snacks. When they're on the medication, they can expect to eat less. And then when they eat less, diet quality is important, and that's protein needs, meeting protein targets. We did those calculations. We want them to keep a food diary if they can, engage in regular physical activity. And then we soften things. These are balanced behavior changes. And then the 80-20% rule. So if you're going to eat out, maybe think about limiting it to once or twice a week. If you're going to have your sweet or treat, save it for once or twice a week. And if you're going to have liquid calories, once or twice a week, right? So we don't eliminate, we don't do elimination diets. We want to minimize those unhealthy behaviors. So my LPN would check off here. Yes, we've gone through the recommendations. I know they've been done. Insurance coverage, are they covered, or are there forms on the chart for me to fill out? Okay, out of pocket, if they don't have coverage, are they willing to pay for the medication? So that conversation has to happen if they don't have coverage. Okay, so again, the medication sheets are similar in the first section. And then they diverge. So this is the liraglutide part 2. So we need to make sure patients meet criteria for a weight loss medication, and we know those criteria. Do they have any contraindications to liraglutide? Okay, so a family history of medullary thyroid carcinoma, multiple endocrine neoplasia type 2, which is very rare. Female patients of reproductive age should be on contraception. Other things that impact decision-making for liraglutide, a history of pancreatitis. Do they have biliary colic? Maybe we should address that first. Renal impairment, hepatic insufficiency, and then contraception comes up, okay? It's always on a kind of on the radar, are they a diabetic, right? Because if they're a diabetic, there's a chance for sure that you may need to adjust their other diabetic medications when you start them on liraglutide, okay? So this is now the naltrexone bupropion initiation worksheet. Again, my LPN will go through, do they meet criteria for weight loss medication? I'm going to bring you guys down here. The absolute contraindications to naltrexone bupropion, there's 3 of them. Opioid use, so if the patient's on any kind of narcotic, if they have a history of seizures, because we're using higher dose bupropion, and if they're a breast cancer patient on tamoxifen, okay? Uncontrolled hypertension, just manage their blood pressure first. We don't advise to use these in patients with eating disorder. And then abrupt discontinuation of alcohol and drugs just lowers seizure threshold, and use of MAOIs is pretty rare, and thiazidine isn't even on the market. Okay, so just remember those three. And then with this one, when you prescribe liraglutide, you think about diabetes. When you prescribe naltrexone bupropion, just keep on the radar what other medications they're taking for mental health possibly. Are they on a bupropion containing medication? Maybe they're on Wellbutrin for depression, or they're on Zyban for smoking cessation. You may need to down titrate those medications as you up titrate the naltrexone bupropion. If they're on an SSRI, they're on an SNRI, or they're on a stimulant, don't panic. You can take naltrexone bupropion with those medications. You just need to monitor for stimulation and maybe anxiety symptoms. If they're on Plavix, also drop the dose of naltrexone bupropion, and then contraception needs to be in place. Okay. So making sure, did you guys pay attention? Let's see. So which of the following conditions or condition is an absolute contraindication to liraglutide therapy? Let me find that question. Here you go, and submit your answers. I'll give you a few seconds here. Just the questions. All right, I'm going to end the polling here real quick. There's a lot of movement, but I am going to end it here. All right, and I'm going to share the results. So the vast majority of you guys thought a personal or family history of medullary thyroid carcinoma is an absolute contraindication. Okay, so the correct answer here is medullary. Don't worry about follicular and papillary. A history of pancreatitis is not an absolute contraindication. It's a precaution more than anything. Okay. Now, which of the following medications or medication is an absolute contraindication to naltrexone bupropion therapy? I'm going to find the question. Yeah, we did have a lot of questions here. All right, go ahead, submit your answers. Absolute contraindication to naltrexone bupropion. All right, there's less movement now. I'm going to end the polling. I love seeing this. All right, I'm going to end it. All right. So again, most of you guys thought being on codeine, right? We're naltrexone, you wouldn't want to give someone if they're on codeine. So A for sure is right. And then as well as tamoxifen C. So the correct answer is E, A and C. Okay, those are absolute contraindications. All right, so part 3, again, my nurse would go in and she would go through, so this is the LIRA sheet. She'd talk about mechanism of action, you know, reducing hunger, increasing satiety. She would review the side effect profile of the medication. She'd talk about the titration of the medication. When we were saying seeing people in clinic, we were doing the FlexPen device teaching. That's being done gracefully by clinical pharmacists in the community now. And then make sure your patients enroll in Saxenda Care. These are great support programs. When we talk about sharing care, PCNs, physicians, patients, burden of the disease, a hard, complex chronic disease, these support programs can really, really lift your patients up. Okay. Naltrexone bupropion, again, my nurse would go through mechanism of action, hunger, satiety, craving, side effect profile. She'd go through the dosing schedule. She'd tell them what to do if they have side effects. So if you're experiencing side effects, the easiest thing is to drop the dose. Let's say they're going for surgery. So for this one, let's say they're going for a total knee replacement or something like that. They're going to go on opioids. They need to stop their naltrexone bupropion 3 days prior to. And then of course, she'll discuss the Contray support program and really encourage patients to access these, what is showing up all over my screen here? Nope. Again, engaging these nurse counselors who are part of the Contray support program really does benefit the patient and helps you as a clinician. Okay. Are you seeing this green writing?
I am seeing that.
Don't know where that came from. Okay, so this is the last part of the initiation worksheet. It's no different between the two. You set a couple of goals with the patient. They usually choose the goals they want to work on. You make sure they come back in 1 or 2 months, not greater than that, okay? And you give them the prescription. So she wants to go on liraglutide, so I write that for her. She's going to come back in 8 weeks. Weight loss expectations. This is how I say it. You know, I know they're coming from a commercial program background. People have lost 30 pounds in like 30 days. So lots of people come from those backgrounds when we're saying we're promoting 1 pound a week. And you just explain to them, do you want to lose 80 pounds, regain it back, or would you like to lose 30 pounds with me and keep it off? And then you talk about the benefits of gradual weight loss, right? The benefits of gradual weight loss. Number 1, they're going to keep it off. Number 2, they maintain their metabolism. You know, they're going to, if they meet protein requirements, they will keep their muscle mass. The whole point of physical activity is the same thing, keeping their muscle mass, keeping their metabolism. It's healthy, gradual, sustained weight loss. Okay, so you have to have that conversation. All right, here's the question. With regards to expectations with various treatment options, which of the following statements is wrong, incorrect? Okay, I'm gonna pull it. You're gonna see it in a second and go. Answer. Incorrect. Okay, I'm gonna end the polling question and move on and share the results. So most of you guys thought with lifestyle 5 to 10% was incorrect. Okay. So the correct answer, or the incorrect answer here, is lifestyle 5 to 10%. If you look at evidence, most people with behavior change will lose between 3 to 5% long term. So Nadine comes back 2 months later. This is great. She feels less hungry. She's trying low-fat recipes, keeping trigger foods out of the house. She's trying to incorporate activity, and that's a hard one. She's lost 3 kilos. This is important. She feels hopeful, right? How patients feel is important. This is just a number. That's a number. How patients feel is what we're targeting. Management of hunger, management of cravings, feeling in control, feeling confident, feeling competent, feeling sure when they wake up in the morning. So they're not like, is this going to be a good day? Is this going to be a bad day? They want to feel good. They don't want to feel deprived. This number is just a consequence of that. So the obesity medication follow-up sheet is streamlined for all of the medications. So let's go through that. Again, my nurse would do this. So patients on liraglutide, she's in the room. She would fill out that she's on 3 milligrams sub-Q daily, put in all of her weight history. She's lost 3 kilograms. Usually her vitals would be there. Liraglutide is covered for Nadine, and she is taking it once a day as prescribed. Okay, so this would be filled out by my nurse. My nurse typically fills out the side effect inventory with the patient, and then after a while, by the 2nd, 3rd visit, the patients actually fill this out while they're in the room. So Nadine's having a bit of nausea. That's not surprising. She's having a change in bowel movement, right? A little bit of dyspepsia, so we'll manage this. Okay, these are not uncommon. And then my nurse will go through the benefits of the medication. So Nadine feels less hungry. She feels more full. She hasn't noticed a reduction in cravings. She's still struggling with them a bit, but she does feel that they're maybe not as strong and she's starting to resist them. She's winning those battles. A decrease in emotional, she's still grazing and snacking a bit, having that wanting, but feels like overall she has more control. She's keeping a diary, tracking her calories. So her target was 12 to 1400. Don't be surprised if people don't meet their protein needs. That's a work in progress, right? And we actually, so we have all kinds of cheat sheets here. So I don't calculate people's protein needs. I have a chart. I look at their height, which is in like meters and feet. I just look over to the right and I see their protein needs. So we have a lot of cheat sheets for all of this stuff. She is having 3 meals most days. She is limiting grazing. She's still struggling with a bit of grazing. She's having some emotional eating going on. She has a lot of stress in her life. She's limiting liquid calories, limiting eating out, and limiting junk food. She's wearing her pedometer, getting 8,000 steps a day. Our target is 10,000 if there's no limitations, and she's signed up for the support program. Okay. So we are going to get her to come back in 2 months, okay, or less than. Once a month would be amazing. We're going to increase protein intake. So again, we have a worksheet for patients. We give them the handout on how to meet protein needs and all the examples and ideas. She wants to work on the physical activity. So we let her set some goals. We help her manage her bowel, get her on a bowel routine. And then with regards to the side effects, you have to reassure patients that they're just mild. They're self-limited. They're gonna improve over time. They can find triggers for the side effects. Some people will say eating heavier foods or fatty meals trigger their side effects, or an empty stomach is a common one, or they can decrease the dose of the medication. Okay, so Nadine does come back 2 months later. Her side effects have resolved, which is great. She's managing her bowel routine. She's lost 8 kilos. So this is about 1 pound a week. She feels confident, hopeful, confident, right? Patients happy, doing well. They're going to stay engaged, right? Continue the medication, and she'll continue to set goals each visit. So she'll say, I want to do this between this visit and the next visit, and you bring her back in a month. Okay? Any questions? Sabrina, are there any questions?
There's lots of questions about access to the form.
Access to the forms. So we are going to give you guys access to our health questionnaire, all the screens, all of our worksheets. We're happy to do that. So we'll set that up and send it out. We share them all the time with PCNs. I have all the documents PDF. So we will definitely give you guys access to those. And then, okay, we've answered that one. Okay, I think I've answered all the questions then, and we'll keep moving forward. And you guys are going to fill out your evaluation. So BB is sending you guys the link, right?
In there. In the chat.
It's in, oh, she's so cool. It's in there. So take 30 seconds, and then we're going to get started with our last speaker. Thank you guys. You guys are awesome for sticking it out. I hope you guys have had something to eat. Okay, so I'm going to get started with our last speaker of the morning. Now we're in the afternoon. Okay, the joke's on me. Dr. Chapelski. Dr. Chapelski. She is joining us now. So Dr. Chapelski completed medical school at the University of Calgary. She developed a special interest in obesity medicine during her general internal medicine training at the University of BC, British Columbia. She is a diplomat of the American Board of Obesity Medicine and clinical lecturer in the Department of Medicine at the University of Alberta. In fact, during her training, Dr. Chapelski spent time with us in the program here. I think she did elective time for at least a month, and we fell in love with her and we kept her. Based in Edmonton, she has a special interest in the management of patients with very high body mass indices and perioperative weight management for non-bariatric procedures. In addition to her practice at the Edmonton Adult Bariatric Subspecialty Clinic, she is director of the Women's Preoperative Weight Loss Clinic here at the Royal Alexandra Hospital, which serves patients with obesity and gynecologic cancers. Lastly, she leads a comprehensive community weight management program at Enhanced Medical. Welcome, Dr. Chapelski.
Hi, thank you so much for that introduction, Dr. Modi.
You have control, yeah?
I do, thank you. So it's important for you guys to know that I have accepted speakers fees and consulting fees from both Bosch Health and Novo Nordisk, both of whom market anti-obesity medications here in Canada. And actually, I should just start off by saying thank you for sticking around at this late time. Please, if you need to be somewhere, don't feel guilty for heading out. I'll be here in 2 weeks and can take any questions that you guys might have then. We have, as outlined before, taken all steps to mitigate bias in this presentation. Okay, so let's get to our learning objectives. Today I'm going to talk to you about the underlying pathophysiology of obesity. And I think this is really important as healthcare practitioners because it really informs how we practice and how we can better deliver care to our patients living with obesity. And so in particular, in this talk, we're going to talk about why early intervention is important and how it impacts the long-term trajectory of this chronic disease. I think it's also really important, and there's been a lot of chat going on in the chat box, which by the way, I've loved. I miss everybody and just seeing you and talking so much. But Dr. Walji had mentioned that she thinks finds it really helpful to talk to patients about the biological factors that influence body weight. She says that it helps manage expectations and helps people understand that we need to come up with a long-term plan. I also see in my own practice that so many of our patients believe that body weight is fully under their control and that they should be able to do it on their own. And when we talk about introducing evidence-based therapies, so for example, bariatric surgery or weight loss medications, a really common response is, well, I should be able to do it on my own. No, thank you. And it's really through providing this education to patients that sometimes it helps open up them to the possibility of trying one of these therapies. Dr. Kwan already introduced this, so we all know the formula for weight loss. In order to lose 1 pound, somebody needs to achieve an energy deficit of 3,500 kilocalories per day. Really, when we look at our behavioral recommendations for what we need to do in order to lose weight, they're really based on this understanding, and they're really designed to support the creation of an energy deficit. So for example, we've already reviewed 3,500 kilocalories divided by 7 days a week would be 500 kilocalories per day. So a really common recommendation that we see is to prescribe a daily energy deficit of 500 kilocalories. And certainly what we see when we look at different behavioral interventions for weight loss, they really do work. So in the light blue, depending on the degree of energy deficit that is achieved, behavioral weight loss strategy can result in between anywhere between a 5 kilogram all the way up to a 25 kilogram weight loss. And this is at the end of that intervention, which would be somewhere between 6 and 12 months. Now, the reason why these studies in particular are highlighted on this slide is because we also have really long-term data on the weight loss outcomes. And what we see universally is that when these patients are followed up anywhere between 4 and 7 years after the end of that weight loss intervention, uniformly across the board, they have regained weight. So why is this? Why is weight loss maintenance so difficult? So here's your poll for this talk. What do you think is the most common reason for weight regain? Okay, I'm bringing up that poll question. Dr. Chapelski's questions. Okay, so do you think it's that people aren't able to maintain a diet? So maybe we're not giving them realistic advice. Is it because people don't have enough time for exercise? We've learned that for weight loss maintenance, the recommended amount of exercise is 200 to 300 minutes per day. So do you have an extra hour in your day to contribute to exercise? Is it that patients aren't able to resist cravings? So we live in an environment where we have really easy access to cheap, delicious food, and we can't escape it. You see it when you're driving home from work. You see it when we used to go out in public, surrounding us at our hockey rinks, everywhere. Is it just impossible to resist cravings in this environment? What do you guys think? I still see some results rolling in. We'll give you guys a little bit more. Beautiful, and I'm gonna end it here. So you guys believe that it's not able to maintain a diet was the most common response. And guess what? I have good news for you. We're going to end on a high note. You guys are all right. Okay, you guys have all given the correct answer. All of these things are important reasons for why patients are unable to maintain weight loss. And for different individuals, one or more of them is going to be more important than another one. Now, what we didn't address in this question is that another really important factor that makes weight loss maintenance so difficult is those internal biological factors. What often goes unappreciated, both by healthcare practitioners and by also is not well understood by patients, is that body weight is something that is very, very tightly regulated by a little part of our brain in the hypothalamus called the arcuate nucleus. When a patient does just what we tell them, they restrict their calories, they increase their physical activity, and they lose weight, what happens is this triggers a number of homeostatic mechanisms that are going to make more and more weight loss more difficult and actually act to promote weight regain. Now, these different homeostatic mechanisms occur on both sides of the energy equation. So we're going to focus on energy expenditure first. Now, it's going to make sense to you guys that if we move a 200-pound object from point A to point B, it's going to take a lot more energy than if we're moving a 150-pound object from point A to point B, right? That makes sense, okay? So with weight loss, we do expect some decrease in energy expenditure. The real kicker with obesity is that when somebody loses weight, the decrease in energy expenditure that we see is actually much greater than we would have expected by that change in body weight alone. And I'm going to describe this on the next slide. So there was a lot of chat we were chatting a lot about the Biggest Loser study. So here it is. So this is a trial that came out in 2016. It made a big splash in the lay public, of course, because it involved contestants of the TV show, season 8, for those of you that are aficionados. It also made a big splash at all of our obesity scientific meetings because this is the longest that a trial of this type had ever been performed for. Each line on these graphs represents an individual participant in The Biggest Loser, and we're going to focus on the winner of the competition. His name was Danny Cahill. Danny started out the trial, I say trial, it was a TV show. He started out the TV show at 430 pounds. And at the end of the competition, through extreme dietary restriction, through extremely intense exercise, he managed to reduce his body weight by more than 50% to an incredible 191 pounds. When they followed up with Danny 6 years later, he had regained much of that weight, and he now is 295 pounds. But of course, what we've learned now is how remarkable this is. It has maintained a 25% weight loss with behavior change alone for more than 6 years. Crazy. Now let's take a look at energy expenditure. So when we look at Danny at the beginning of the competition, he's at plus 200. What this means is that compared to another 40-year-old male who weighs 430 pounds and has the exact same body composition, Danny's actually burning 200 calories per day more than would be expected. And we can surmise that this probably gave them a bit of an edge in this competition. At the end of the competition, he's now at minus 600. So what this means is that now Danny is burning 600 calories per day fewer than would be expected for a male who weighs 191 pounds. So Danny doesn't just need to do what the average 190-pound male needs to do in order to maintain his body weight. He actually has to walk for fully 2 hours a day extra to make up that difference. Where was he 6 years later? Extremely surprisingly, he's actually now at minus 800. So now Danny doesn't just have to walk for 2 hours extra a day, he actually has to sweat for 2 hours extra a day in order to keep his body weight at 295 pounds, okay? Okay, so that is the energy expenditure side of things. Now let's take a closer look at energy intake. Now, you guys will, I'm sure, all be familiar with that there are a number of peripheral hormones that influence our feelings of hunger and our feelings of satiety. Some of these hormones operate over the long term. So for example, leptin is going to serve to regulate body weight over weeks and months, okay? There's also a number of hormones that act over the short term. So for example, ghrelin, CCK, the levels of these hormones will actually fluctuate tremendously throughout the day and act to either promote the initiation of eating or to promote the cessation of eating, okay? Now, we've already learned that, or introduced this basic concept that when somebody does all the things that they're supposed to do in order to lose weight, homeostatic mechanisms are triggered, which are going to promote weight regain. So I know that you guys can now all guess what happens to the levels of these hormones in somebody who has lost weight. Well, those hormones that make you feel hungry, ghrelin, are going to increase. The hormones that make you feel full, like leptin, CCK, those are all going to decrease. All of these signals converge on the hypothalamus and overall act to promote an increase in energy intake and an increase in body weight, okay? Now I want you guys to just take a moment and think about a really common clinical scenario. So we have a patient who's done everything that they're supposed to do, made dietary changes, increased their exercise, and has lost, let's say, 10% of their initial body weight. They're now coming and presenting to a healthcare provider and saying, I'm doing everything I was just doing before, I'm not losing weight anymore, and I still want to lose weight. Well, a really common outcome of that clinical scenario is that they are advised to restrict their energy intake further, right? Just at a time when we know that there is an increase in the hormonal drivers for food intake, just at that time where we already know that it's going to be even harder than it was when they started to restrict their energy intake, okay? So how likely is that person going to be successful at reducing their weight further? Now, when we're looking at this process called hormonal adaptation and metabolic adaptation, like we talked about before, these are changes that actually have been shown to persist for as long as we've ever measured them. And so this is really the biological basis for why obesity is a chronic disease. But we also know that obesity is a progressive disease. So I know that you guys have all met patients in your practice, like Michael. He's carried weight for a long time. He's successfully lost weight on a number of occasions, but always gone on to regain. And now he's coming in and telling you, I'm doing everything that I ever did in the past to lose weight, and it's not working anymore. You also have patients like Jennifer. Jennifer was normal weight as a child and teenager. Throughout adulthood, her weight has slowly been increasing. She's tried to lose weight in the past and was successful, but went on to regain and then some, okay? So what are the biological processes that underlie the progression of obesity? So we're gonna focus in on that arcuate nucleus within the hypothalamus. And within the hypothalamus, there's two competing neuronal pathways. So these CART-POMC neurons are responsible for satiety signaling, whereas these AGRP neuropeptide Y neurons are responsible for hunger signaling, okay? And so it's the balance between these two that act to promote or inhibit eating behavior. And it can also be said that it's the balance between these two that really determine body weight set point, okay? Now, all of you know that in obesity, a number of our weight-related health issues are because there's an increase in inflammation in various tissues of the body. Now, in patients with obesity, there's actually also an increase in inflammation in that very part of the brain that controls body weight, okay? Now, in this part of the brain, it's particularly the glial cells. So you remember glial cells are those cells that surround and envelope the neurons, and they help support the health and function of these neurons. So these glial cells are particularly affected, and with that inflammation, we actually see scarring, and this can actually be seen with brain imaging. Now, with that inflammation and scarring, we see cellular apoptosis, cell death. And I bet you guys can all guess which of these pathways is going to be more affected, right? So it's going to be this one, okay? So over time, what we see in obesity is that there's actually a diminished capacity for satiety signaling. Hunger signaling is going to predominate more and more over time, and effectively this leads to an increase in body weight set point. Now, this is the story around homeostasis. You know, the sum of this is that we really can understand obesity as a disease where there's a problem with energy homeostasis, okay? That said, we also know that we don't just eat for energy balance, we also eat for pleasure. So hedonic eating is also a really important driver for increased energy intake and has an important influence on body weight. So when we're talking about hedonic eating, we're talking about the motivation to eat, so the wanting of food. We're talking about the pleasure and reward that's associated with eating, so the liking of food. And in those circumstances where somebody would describe a strong wanting of food and intense pleasure associated with eating a certain food, this is what's called a craving, right? What we see is that cravings are experienced very widely by people. About 30% of people with normal weight experience cravings. But interestingly, cravings are significantly more common in people who carry extra weight, and even more common in people who carry extra weight and are trying to lose weight, okay? Now, this phenomenon is something that we see when we poll people, and this is a really recent survey of Canadian adults, but it's also something that we see on a cellular level. So when you compare somebody who weighs 70 kilograms and has always been at that body weight to somebody who weighs 70 kilograms but has lost at least 10% of their body weight to get there, what we see is that when you show people pictures of delicious looking food, we see a lot more activity in those mesolimbic regions, okay? So again, it's not just that people who carry extra weight and have lost weight have to do the same thing as everybody else in order to maintain their weight loss. They are actually have to work much harder to manage and resist those cravings. Now, the final part of the brain that's really important to eating is, of course, the frontal lobe, right? So signals from both the mesolimbic areas and the hypothalamus are going to converge on the frontal lobe and result in the final decision about whether to start or stop eating. Coming up in 2 weeks from now, Dr. Kular is going to talk to you about mental health disorders associated with obesity. So he'll go more into this. But I think something that's also really important to recognize is that there's also changes in how these different parts of the brain talk to one another in patients with obesity, how they're interconnected. This is part of I guess I'll give it away. When we're talking about those psychological interventions that we use, that Dr. Kwan talked about, so cognitive behavioral therapy, acceptance and commitment-based therapy, really what we're talking about is how can we change the interactions between these different parts of the brain. Okay. So to summarize, obesity is a chronic disease where there's a problem with energy homeostasis. Body weight is something that is very tightly regulated. And when somebody loses weight, there are going to be homeostatic mechanisms that are triggered that are going to promote weight regain. On the energy expenditure side of things, we see that when people lose weight, their energy expenditure decreases. On the energy intake side of things, we see that there's hormonal adaptation, so an increase in hunger hormones. We see that there's changes, and insofar as we know these changes are permanent within the hypothalamus that lead to an increase in body weight. And we also see that there are changes within the mesolimbic system. So there's an increase in the frequency and the strength of cravings. So let's now go back to our patient. So how might you guys communicate to Michael why he might be experiencing this, this increased difficulty in losing weight over time? And I think I'll leave that for you guys to maybe put some responses in the chat box. I'd love to hear if this is something that you guys have maybe already been sharing with your patients in practice. And I'd love to know the specific words that you use, because certainly when we're talking to people without a medical background, it's really important, and we all sort of find our own language that really resonates with patients. So I'd love to have some new ideas from you guys if you have. Okay, so I wanted to finish with this slide that was the product of our newest clinical practice guidelines that were released over the summer. I think really classically, it's been taught and it's been believed that changes in nutrition and changes in activity are the foundation for weight management. But when we now take into account our new understanding of the biological factors that control body weight, instead, there's sort of been a reworking, and we now know that creating an energy deficit, which we do through changes to nutrition and changes to activity, is what is needed to have weight loss. When we're talking about treatments for obesity, however, we're looking at those interventions that are going to help people create this energy deficit and to maintain it over time, okay? So for example, We have psychological interventions. And as I mentioned briefly to you guys, when we're talking about CBT, ACT, we are really talking about things that rewire how the different parts of the brain that control energy intake talk to one another. When we're looking at our weight loss medications, these all act on the energy intake side of things. So they act on the hypothalamus and act within the mesolimbic region to help support people in managing their eating behaviors and taking in fewer calories. When we look at bariatric surgery, we also see that it changes, for example, energy intake by influencing all of those peripheral hormones that promote weight regain. And we also see a suggestion that it actually affects that change in energy expenditure that we typically see with weight loss, okay? And I think it's important to keep this framework in mind as we look ahead 2 weeks when we're going to talk more about medications, bariatric surgery, and mental health. Okay, with that, a few final thoughts. As we said, obesity is a chronic and progressive disease where there's a problem with energy homeostasis. Early intervention is really important because it's going to alter the trajectory of the disease, and it does so at a basic central level within the hypothalamus. And lastly, I wanted to leave you guys with this. I think often healthcare practitioners, when we meet somebody who has lost weight, gained weight, lost weight, gained weight many times in their life, often these people are viewed as people who lack motivation. They know how to lose weight. Why don't they just keep doing what they were doing? Patients also often think of themselves that way. However, really what's happening in these patients is that a person who's come back time and time again to weight loss efforts, this really signals somebody who is highly motivated to manage their weight. And what this means is that those biological factors are playing a really important role in influencing their body weight and weight regain over time. And I think when I think about, we're all sort of hit with this difficult decision of who do we spend time with working on body weight. These are often the patients who, first of all, are going to be really receptive to these messages about obesity being a chronic disease, and they will have lived and have a lived understanding of the biological barriers that make weight loss really difficult. And so these are often the patients who are at a point where they are just really ready to have a healthcare practitioner on their side and really ready to have a discussion about those evidence-based treatments that we have. I'll leave it at that.
All right, Sarah, there are a couple of questions here. I'm going to start with this one because it's actually probably a very, very important one. Do you have smart links and smart phrases set up on Connect Care that you can share?
Oh man, was that from Julia Lynn?
I don't know. It's a great question because I actually think like we do, and we should share them. Like,
yeah, I do have a few that I have. So for example, I have so I guess I'm not sure if this meant, because we do have that patient sharing feature with Connector, which I have to say I'm not been using, but I certainly do have several that I use when I'm communicating, for example, with our referring physicians who may not have the same understanding of obesity. So for example, I have one that really counsels people about the long-term need for weight loss medications and why we need to continue prescription over time and how to maybe continue to have a discussion with patients about that over time.
Okay. Yeah, so I actually think if you email us directly, if specific people are on Connect Care Live and they're wanting resources, then just let us know directly. We're all in this together with Connect Care.
Absolutely. I was just going to say, I'm so happy to share resources as long as you share them back when you make them better.
I was just going to say, we can all be on the same page, even in our province, for example, like just creating a highway and sharing information and templates and stuff and just constantly revising, making things better. Do you ever access help from PT, OT, so physio occupational therapy, regarding patients that have comorbidities, like so chronic pain issues, MSK problems like OSA, to help with exercise and lifestyle, ADLs, things like that?
Listen, I don't do it enough is really the bottom line. I think, you know, and Sabrina sort of alluded to it. We are always so happy when we help people lose weight and they're now able to do things. They are able to, you know, tie their shoes, able to keep up with body hygiene better. I know that our occupational therapists also have a lot of tips and tricks and tools that can be so helpful for patients, and I'm not using them enough for sure.
Okay, and then there's another question. Do we need to work together